Good morning, everybody. I really would like to welcome everybody here today. I'm Judy Silverton, Chair of Bereavement Care's Conference Planning Group, and I'm delighted to welcome you all to Bereavement Care's 40th annual conference. It's a long journey, the length and complexity of prolonged grief. Now, this is our second virtual conference. I have to say, I looked at my notes from last year's conference and I find it hard to believe that we are actually holding another one online. It's amazing, isn't it? I do believe that Zooming has been an absolute lifesaver for many of us, and the technology has allowed us to communicate with our loved ones, keep connected. Now, the conference planning group made the decision back in April, right at the beginning of this year, that face-to-face events might not be possible for everyone. There are countless numbers of people who are still very, very wary of crowds, and many who don't feel comfortable about meeting inside, even if they are double vaccinated. Now, the overriding principle which keeps us using Zoom and prevents us from meeting in person and in large groups is that we don't want to endanger any lives or even carry any risk. 19 months, yes, 19 months after the beginning of the pandemic, we still do not fully understand this virus, and we can only follow the advice that the experts give us. But we're social creatures, being separated from the rest of our circle, our friends, our family. It's been a very difficult thing, especially at a time of grief. Now, a year on from our last conference, we are still experiencing so many losses: sadness, grief, sorrow, anguish, misery, regret. Feelings of guilt are still uppermost in our minds. Even the most optimistic of us, and I am one of those optimists, have had emotions from time to time. The pain is still there. The feelings may have become more complex. They're compounded by the fact that life that has not quite got back to our normal, or at least some kind of pre-pandemic normality. Many bereavement visitors are not able to meet their clients, not face-to-face. Phone calls can be difficult. Not being able to see the person, people's faces. When we do our initial bereavement training, we're taught that we need to listen to the silences. Let our client cry. This is really difficult when you're doing it on a phone. Are you there? Have we been cut off? Having said that, I have one client at the moment who doesn't want to meet in person. She likes the anonymity. She likes the confidentiality of a telephone call. Today we will explore some of these issues and get some practical strategies to help bereavement visitors. I know that this will enhance their skills to improve the way they work. Now, please let us have your feedback. It's really important about today's conference. It's so important for us to know and get your reaction, not only about the administration of the conference, but most significantly, to let us know what topics you feel are important. There will be a certificate of professional development that you'll be able to get from the website I think you'll get an email after the conference. Now, questions. Please send your questions in via the chat facility. This is going to go to Sharon Goldstein and Bobby Riesel, who are on the committee, and they will monitor the live questions and answers for the session. During the interval, we will be showing a short film to mark Bereavement Care's 40th anniversary. It's been quite a journey, a long journey in fact. Just look at the variety of subjects that we've covered over these years. It's quite extraordinary. I'm now like to hand over to Robert Freudenthal, and he will start by giving a short presentation, and then we will have a chat. He's going to explain a little bit about what he does and how this is going to work. So I'm delighted to hand over to Robert. Good morning, Robert.
Good morning. Thank you very much for the invitation. I'm just going to share my screen. Um, so good morning. So my name's Robert Freudenthal. I'm a general adult and old age psychiatrist, a registrar in those specialties. And I currently work in Islington Memory Service and an older person's mental health ward in Islington. And it's really wonderful to meet you all today and to be welcomed to the conference today. It's always really great from the secondary mental health service perspective, meeting people that are doing the hard work in the community of supporting people at time of need, at loss, and of bereavement. So I'm just going to give a short presentation, just talking through some of the issues that I have faced and we have faced as mental health services, some of which you may be familiar with, and then we'll move on to a discussion later on. So I just wanted to start with this grief cycle. I'm sure that you are all aware of this, and like any model, it's helpful for some and less helpful for others. But I think it is helpful just to anchor that sense of journey, really, that we've all been through over the last 18 months and are still going through. And like any journey, it's never straightforward. It's never just unidirectional, and there are steps and missteps along the way where you may go forward and go backwards. But it does map on somewhat to some of the mental health experiences that some of us may have had, from denial, that sense of shock and elation, which is commented on this slide at the beginning. And I think a lot of that does ring true for some of us. That sense at the beginning of, gosh, we're in a crisis, we must do everything we can to support one another. And that slight sort of manic energy that we had, stepping out on the doorsteps, cheering everybody, and of course that can't be maintained for a period of months and months and over a year. And then as we progress through this cycle, we have anger and then depression as some of the realities of what we're facing with, and the truths of the losses become more apparent. Bargaining, and then acceptance. And sort of one caveat is that I think this model does sometimes give a bit of a sense of there is one path that we should all go through, and you've sort of reached closure once you get to the end of it. And we know that that's not the case, and that whenever we experience other losses or other difficulties, then you may go to the other steps of this cycle. But I thought this is a helpful thing to remind us of, to anchor the journey that we've been through. So I want to talk a little bit about the losses that we faced. Some of the losses are obvious and some less so. So of course, on our minds today is bereavement, and that will be both bereavement, of course, from people who've sadly died from COVID illness, but also all the other ill health difficulties people have had in the last 18 months, some of which may have been exacerbated by the restrictions and so on, and some of it may have just been things that have happened anyway. But clearly in 18 months, we do accrue a number of losses just through the natural life cycle. And then there's also the financial losses that some have experienced, a loss of earnings, for example, if their business has not been able to function in the normal way. And then perhaps slightly more crucially, from a mental health perspective, a sense of loss of identity and loss of role. And in my current post as in old age psychiatry, I come across this all the time. So people, for example, who may have had a role as perhaps as a grandparent, caring for grandchildren, of course they still are grandparents, but if they're not able to do all the same duties that they previously had done, that's a real loss of role and sense of identity. And then at the bottom there, communal life is really, really important to our mental health. It's very important, in my view, to have relationships with friends and family, which we've already spoken about this morning, but also to have relationships beyond your friend and family network, a communal life. And that might be with neighbors, or in community structures, or faith communities, or organizations like this. Or anywhere really where you might meet people who are outside of your immediate friend and family network. And those relationships are really important in order to meet people that are outside of our so-called bubble, and may feel and think and see things differently to oneself. It's so important to meet with people that we might disagree with, and that helps ground us and keep us sane. And it's been a huge, huge loss that a lot of those structures of communal life have not been able to be continued over the last 18 months. Of course, some are now getting back to meeting now, but many people still aren't able to participate in those communal structures, and this is a really, really significant loss. This slide I wanted to show, it's called the blob bridge. It's actually normally used in adolescent mental health, but I think it's a wonderful picture, which I just wanted to show you all. So the way that it's used is for a young person that's maybe struggling to talk about their emotions. You might show them this picture of all these different people and say, you know, which one of these people matches how you're feeling at the moment? And I think it's a wonderful illustration just to show how varied our responses are. So over the last 18 months, we hear a lot about the losses and the difficulties that people have faced, but we have all responded to them in completely unique and individual ways. All of our responses will be different. And so we hear a lot about the mental health challenges of lockdowns, but for some people, there may have been something quite appealing about not having to go out and being able to withdraw from community life. And so we must not make any assumptions about what any individual's experience might be. And if I just point out to a few of them, you know, you have people who are kind of hanging off the edge of a bridge, who are, you're struggling and feel like they're dropping into a crevice and they can't see a safe way forwards and they're just hanging on with their fingertips. Or you see this person on the edge of I'm not sure if you can see my cursor there, but on the edge of the crevice, who's kind of reaching out, like really wanting to help people who are falling and not really able to, and how desperate that must feel. And then you have the people that just withdrawing into themselves, feeling chained and locked. And then those people that are really enjoying, greeting more people, maybe meeting people across the world through technology, which we haven't been able to before, or people that actually feel more connected than they had done previously. And what I want to really draw out is that these reactions are true both in our response to the threat of the virus, that threat of becoming very sick or making someone else in your network or one of your loved ones very sick, and the response to the restrictions. So some people may respond to that threat of virus and think, my goodness, we must do absolutely everything possible to avoid becoming ill. And that's, of course, a completely understandable response in order to protect life. And so we'll be perhaps standing on the bridge looking out for everybody, for example. And then you may get people that have really struggled with the restrictions and feel that the restrictions are locking them down. So perhaps like this person here. And I just want to share one short anecdote from my clinical practice just to illustrate this, which is to illustrate, I suppose, some of the emotional content that some emotional experiences some of us have had over the last 18 months. So it's a woman that I met with who previously, an older person who prior to the pandemic was going out most days of the week, going on day trips, going to parks and different activities. And she described to me that when she saw the announcement about the lockdowns, although she understood where they were coming from, she said to me, I couldn't understand how someone could do something so brutal and tell me that I couldn't leave my home. I felt like I was being shut down as well as being locked down, and subsequently developed a mental health crisis. And I think these experiences are perhaps more common than we might think. There's a lot of discussion in the news about the prevalence of mental health difficulties and how they've increased, but perhaps not so much about the actual content of what that experience has been like for people. So likewise, I've had other people who said that they found the restrictions very reassuring, and it's been very positive to have that guidance and to know what to do. So yeah, do bear these little blob creatures in mind when you're seeing people, just to think about the whole plethora of responses to any individual crisis. And there've been some I wanted to just quickly touch on some of the broad areas of mental health difficulties, just for you to be aware of. And the reason I wanted to mention this is that again, there's been lots of focus about the increase in prevalence of mental health difficulties across the population. But I think a bit less focus on what life has been like for people who already have severe and enduring mental illness. And you may be, there may be people in this room who fall into that category, or you may be visiting people who already have a severe and enduring mental illness. So with any mental health difficulty in the severe end of the spectrum, there's likely to be an impairment in day-to-day functioning. So that means an impairment in being able to do the things that you may wish to do on a day-to-day basis. And of course, in a world where lots of the things that you might normally do have stopped, then de facto, there is an impairment in functioning. So there's already, by sort of definition, a deterioration in someone's mental health because there's less that you're able to do in a more restricted, during the periods when there have been significant restrictions. And then just to touch on a few of these difficulties. So clearly with depression and anxiety, particularly anxiety, where we're being asked to be very mindful of our physical health and be very careful about how we interact. Clearly that can precipitate anxiety if someone might already have difficulties with that. Paranoia and psychosis, it's been really hard for people who already suffer with paranoia, where they already feel that they are under threat in some way by external forces, by government, by members of public. You can see how if you are then instructed that by standing too close to people or by getting into a crowded room, that other people, that you may be put at harm, that could get oneself into quite a paranoid mindset. And so therefore, people with paranoid psychosis, that some of those symptoms may deteriorate. People with eating disorders where they, particularly with a more restricted type of eating disorder, in more restricted eating disorders, for example, anorexia nervosa, you might have a very restricted life. It tends to be the case that as one's eating is restricted, so do other areas of your life. So, for example, your social contact, and you may socially withdraw. So in a climate where we are all facing restrictions, then those restrictions are likely to come out in the form of eating as well. And so people with eating disorders have really struggled over the last 18, 19 months. Then people with dementia or intellectual disability who may really rely on a particular routine in order to manage their day-to-day life and also to give their carers a break. When that routine has been disrupted, we've seen an exacerbation in behavioral difficulties, including aggression in some cases. And this has now been borne out with data showing that sedative medication has increased in people with dementia over the last 18 months. So people with dementia have had a really, really rotten time. And then substance misuse, it's alcohol has become something that many people have turned to. And if you already have difficulties with drug or alcohol dependency, and then a lot of your support structures have closed, so perhaps going to faith community or AA groups or whatever that might be, then there's been an escalation in some of those difficulties. But I also wanted to draw out this point, which I find very helpful, about psychiatric illness as being a prompt for understanding society. I find this very, very useful. And when I discuss it with patients, I think they find it helpful as well, as a way of destigmatizing some of the experiences. So what I mean by this is that when somebody, for example, say, for example, somebody who has a psychosis and it perhaps has been paranoid about being watched and monitored. It's a very common paranoid delusion that people have, that they're being monitored by external forces and their cameras watching them, for example. It's helpful to think of that not just as a product of a biological mental illness, but also as perhaps telling us something that might be happening in their life experience and in the experience of their communities and wider society. So, for example, in a situation where you might have, for example, a young Black man that is this is describing being monitored and surveyed by external forces, you might think, well, perhaps there is also, as well as this person having a mental illness, there might be something going on for this person that means that they are understandably fearful of being surveyed and overly followed. So it's really helpful to see some of these difficulties and illnesses that we see in people with mental illness as a useful way of understanding some of the forces that are happening in society, really. So that another way of describing this is that people with a significant mental illness are in a way expressing something for themselves, but also on behalf of all of us. And that means that when we think about how we can support people, we need to think both about what they can do to help themselves and what they could maybe do differently, what treatments and support they could access, but also what we could do as carers and what changes we'd like to see in our communities to make these things easier to live with or less prevalent. Now, I was asked to give some practical strategies. So I think there's some very simple things that we can all do. A lot of it is really just to be aware of some of the things which we're talking about this morning. So, for example, to discuss the importance of occupying different roles. We all need to be cared for and be carers, and there are, to obviously greater or different extents according to the individual person. And clearly there are times in our lives, for example, at bereavement, where you maybe adopt a more being cared for type position. However, as you move through your grief journey, then there will be a building up of those other roles. So as well as being somebody who's being cared for, building up that role of being a sibling, a partner, a carer, a parent, a grandparent, whatever it might be for an individual person. Discussing some of the challenges openly, I find, for example, that blob illustration really useful, just to illustrate to people, these are all the different experiences that people might have, and perhaps I'm not even, and there'll be more experiences yet that we haven't even thought of, and to really give a person space to talk openly without judgment about what their experience and response might be, with no expectation of any particular response to the pandemic, and to really keep an open mind about how someone may have responded. Of course, if you're faced with disturbance which you feel is you're unable to manage, or feels that the person would benefit from further help, do ask for help. I'm sure you have internal supervision structures, but do address those and signpost on to psychiatric services via your GP if you need to do so. It's always helpful to focus on the underlying emotional impacts. And what I mean by that is that it's never, I'm sure you're all familiar with this, but just to remind you, it's never that helpful to get into a back and forwards with someone about any particular behavior, whether a particular behavior is helpful or not. It's always better to focus on the underlying emotions. So for example, instead of saying, would you like to do this or wouldn't you like to do that, perhaps get to a position of how stressful might it be to do this? And then you can get to perhaps a more problem-solving perspective. And then tying back to what we said at the beginning, it's so important to have connections beyond your immediate friends and family. So to think with people about how can they reconnect with their social networks on Zoom, maybe, if they're not willing to meet or not able to meet in person, and including in the context of bereavement, revisiting rituals that perhaps were missed due to the lockdowns, and thinking about in your particular faith community, for example, if there is one, is there something that could be done at its anniversary? Or if there isn't, could you create something and bring people together? Of course, one of the things about funerals which has been missing in the last 18 months is that funerals is an opportunity to reconnect with family members beyond the immediate family. Often you'll have an extended family present, and that opportunity has been missed over the last 18 months. So perhaps to think with people about how can they connect with those people if they weren't able to at the time of loss. And this will be my last slide just before we go on to a discussion. So this concept I felt very helpful, which is that ultimately empathy and agency, I feel, are the two biggest tools we have to help people who are in a state of mental distress and a state of feeling stuck. When any of us are in experience mental illness or any kind of state of severe emotional distress, we can feel terribly stuck and out of control, really hard to manage. And anything that you can do to help that person feel a bit more control and like feel that they have a bit more sense of ownership over their life, which is very hard to do when you're in an environment where you so many things aren't possible to do, but anything that you can do to do that is helpful. And for me, this is particularly useful in more institutional environments where I work, like on a mental health ward or in a care home. But I think it's true also for people in their own homes to just think to yourself, how can I increase this person's sense of agency? So for example, perhaps I'm not sure what your structures are with how frequently you might see someone, but giving them a range of options for when you might see them again and letting them choose, for example, is one way, if that's appropriate within your organization, that's one way where they may feel that they have more control. And if you ever get stuck in a conversation like we all do, and we're not sure what to say, I always resort to two strategies. One is silence, say nothing at all, and wait. And the second thing is to repeat the client's words. So to use their own language. These are the two most helpful strategies, I think. And if you get stuck, I think they will always serve you in good stead. So that's the overview I wanted to give to you this morning before we move on to our discussion. So I'm just going to stop my screen.
Thank you, Robert. That's very interesting, and thanks for the overview before we start our discussion. I'd just like to say I think I might have said the wrong thing about the questions and answers. Could you please, and I'm speaking to you delegates out there, could you please put your questions to the Q&A function, which is at the bottom of your screen, not the chat function. My fault. So I'd like to start our chat, I think, really, Robert. Is there a difference between adults and teenagers whose lives have been on hold? I mean, it's the sort of coming of age-related milestones that we've all had, adulthood, and both academically and emotionally, birthdays, that kind of thing. And is there a difference between adults and teenagers?
Yes, I think that there is. And what I would add to that is I think that these last 18 months have been particularly challenging for anyone going through a particular transition in their life. So, and of course, we'll all go through transitions at any point in our life, but that the adolescent period has got more. Everybody who's going through adolescent will be facing significant transitions. But I think it's also true for an adult going through a bereavement or a divorce or any job change, for example, any significant change. This has been particularly challenging. I'd also like to suggest that another group of people that has been really, I feel a bit neglected perhaps in some of the focus. We've heard a lot about, and rightly so, a lot about the challenges that adolescents have faced, but also older adults, so adults going from that stage of perhaps being more independent to being more dependent. That is just as challenging a period of your life as adolescence. And those adults, I feel, have had a really, really tough time over the last 18 months as well. I think underlying some of our response, and I don't mean this to criticize the response, but just to sort of bring this to the forefront, is that there has been a bit of a sense, or maybe it hasn't been spoken about, that there's been a sort of belief that it is possible to put your life on hold for 18 months, put it on, and I know that Judy, we spoke about this when we were preparing, but to put your life on hold for 18 months and then like on freeze, and then to pick it up again and think that everything will sort of go back to normal as it was before. Now, that probably is, in a way, is possible for some people. You know, if you're in a very stable part of your life and have a very secure home and secure relationships and have a stable setup, then perhaps you can do that. But if you are a teenager, or if you have a degenerative illness like dementia, for example, then of course you can't put your life on hold for 18 months. You don't necessarily have those 18 months, or when you come back to it, things might be in a very different position. So yes, I do feel that where we are on the sort of life journey has had a very significant difference. And we in mental health services are seeing huge, I don't work in adolescent mental health, but I understand from my colleagues that they're seeing a huge increase, a rise in referrals, and then also in the older adult population as well.
Yeah, I mean, I'm not surprised about that at all. Now, I don't want to put words into your mouth, but a phrase that I've used and other people have used is what we're going through some kind of post-traumatic stress? I mean, we use it. It's a phrase that's sort of bandied about a bit, and I don't want to put words in your mouth, but is that how some people are feeling?
Yeah, I think so. And I think a lot of these concepts for mental illness, as we apply them to individuals, I think they can be applied to communities and groups and countries, perhaps, as well. And I think PTSD, post-traumatic stress disorder, is one way of looking at it. So that would be thinking that, okay, we've experienced this trauma. It probably would come under the category of a complex trauma, which means that it's not one individual. You have PTSD, which would be following one individual trauma, like a car accident, and then complex PTSD is trauma which has been repeated over a period of time. So in the case of, for example, an abuse. And this would probably be under that category because it's been repeated traumas, repeated losses over an extended period of time. And then in the psychiatric sense, after that trauma is finished or as we're moving forward, you then have these senses of anxiety, hypervigilance, so being very sensitive to threats, for example, and responding in a sort of over zealous way. And I think that is one way of looking at it. But to be frank, I actually think that all the different mental health categories that we can think of could equally be applied to the situation. You know, we could equally apply the concepts of depression to us having all had to go through a period of a low mood where we've withdrawn ourselves and withdrawn into oneself and reduced our social contacts, or even, as I mentioned, psychosis, where we've been asked to be, and I don't mean psychosis to say that means that we've detached ourselves from reality, because clearly the threat has been very, very real. But I mean psychosis to mean that, well, we've been asked to feel that frightened of our fellow citizens, which is obviously a very difficult state of mind to be in. So I think that, yes, we can use all these different frameworks for thinking about the experiences that we've been through, and these frameworks can exist alongside one another. And of course, they resonate. Each
I
one
mean,
may resonate more.
there was a time when I stopped watching the news when it was really bad because I just felt that I was waking up listening to it, going to bed listening to it, and it was just too much. It was overwhelming.
Yes,
Um,
yes,
and so I felt bad sometimes, but I thought I'm not going to watch the news. And I think that's something that people could do. It's a positive thing by not watching the news when you're in that period.
yes,
Um,
yes,
yeah.
absolutely. Yeah.
So, are there? Do you find that the pandemic increases severe, persistent, and disabling grief? I mean, has it? Has I mean, I'm assuming, or I've been told not to assume anything, but it would never assume. But it must increase the persistent and disabling grief.
Yes, yes. I mean, yeah, of course, not to make any assumptions for any individual's experience. Maybe I'm sure there must be some people that felt relieved that they didn't, have to go through a funeral, for example, because that can be a stressful experience for an individual person. But yes, by and large, I'm sure it has done. And for my own clinical work, I've certainly met particular individuals that have had all sorts of difficulties in managing with their grief and their loss, because the normal things that we would do at a time of loss or a time of bereavement have not been possible to do so. And that's been the case um, from preceding the point of death to then the whole mourning ritual and period afterwards. So, for example, in the case where somebody has died in hospital, not being able to go visit them in hospital has been exceedingly difficult, clearly. and not being able to say goodbye to one's loved one, or people in care homes and not being able to visit them. And along with that goes a sense of guilt, perhaps, particularly in the care home situation, where you feel people may feel that they somehow done something incorrect to have led for their person to be in a care home in that way. Of course, and no one should be felt to be guilty in that way, but you can understand you can understand from a compassionate perspective why that might be the case. But yes, and so we're seeing really across the board in mental health services, people who've experienced grief and experienced loss that present then come developing significant mental illness, and that mental illness wouldn't necessarily just be, I don't mean just to minimize it, but it wouldn't necessarily only be depression, but really mental illnesses across the spectrum we've seen in part as a result from disrupted grief. The one thing I also must say is that, and I guess this is a truism, but it's really important to bring it to the forefront, is that I think there can sometimes be a tendency to think, just X leads to Y leads to Z, for example, so that one loss and then a disrupted grief process then leads to a mental illness. Of course, it's always more complicated than that. And you can never point to one individual factor for leading to a kind of severe and enduring mental illness. It's always more complex than that. But certainly it has been a big factor, I think, for a lot of people.
And how does that impact on the caregivers?
Yes, so yes, well, I think that's a really good question, because as well as the focus, I mean, I'll talk a little bit from a psychiatric service perspective, and then also from a caregiver's perspective, when in a situation where people develop more severe and mental illness. But there's been a lot of focus on the increased prevalence of mental health difficulties and the wait times and so on, but not so much on how difficult it has been to provide mental health treatment. So the idea behind most mental health treatment, most mental health teams subscribe to this model of what's called biopsychosocial mental health care, which means that you provide alongside perhaps medication, if that's thought to be helpful, also providing talking therapy, but also social interventions, meaning helping people reconnect with themselves and the people around them and the world around them. And that's so crucial to having good quality mental health, is feeling connected with oneself and the world around you. And of course, that's very, very hard to do in a situation where communities are not meeting, for example, or in the mental health setting where mental health groups or mental health day centers or so on are not meeting. So the actual delivery of mental health care and support has been much harder. And then for the bereavement visitors, I'm sure that for delegates in this call would have experienced this, is that perhaps some of the normal things that you might have suggested to someone or helped talk someone through, like would it be helpful to consider going to your local community if you have one, or reconnecting with different family members or friends or wider networks. I'm sure it's been much harder for people to do that because those things haven't been in place. So of course, it's definitely impacted the kind of care that people are able to receive.
Thank you. And by the way, everyone, please keep your questions coming into the Q&A at the bottom of the screen. I think what you were saying is interesting because it's the impact that it's had on everybody, and the fact that the mental health, the NHS, is under such a strain as well. I know one of the things that the bereavement visitors have done is maybe visit people much sooner, visit or speak to people more quickly than they might have done. I mean, sometimes people might leave it 6 weeks till after somebody's died, but we found that there are people who are wanting help immediately, just someone to talk to.
Yes, yeah, that makes sense, I suppose, because if people may have previously relied on other relationships in that immediate period, and perhaps those relationships are harder to call in, if they're worried about meeting people in person, for example.
Yes, and people who are not able to continue with some of the mourning rituals that they might have and not have those people about them. And there's that feeling of emptiness after the funeral because nobody can come round to see you because you know, that they've maybe had COVID, or they've been in touch with somebody that has, and had to have a PCR test and so on.
Mm.
Um, I just wanted to ask you, grief can be prolonged by not expressing how you feel, which is kind of the opposite of what I was saying about speaking to people quickly,
Mm.
keeping your thoughts to yourself. This is where our visitors come in. How do
Mm.
you suggest that we adapt to this, though?
Yeah, so it's something which I feel very strongly, and I've touched on this already, is that we really, in order to help ourselves feel more grounded, we need those relationships with friends, family, and also people beyond friends and family. And the bereavement visitors, I suppose, would come under the category of people beyond someone's immediate friends and family network. And some people, of course, may be isolated and may not have a significant friends and family network. So those relationships with the bereavement visitors are absolutely, it's a key part, I think, in helping someone feel grounded and rooted in themselves and in the world around them. So if they are the type of person, or have not been able to talk much about their grief, then even just having that contact with someone else, whether that's on phone or in a visit, will be helpful, I think, in helping the process. And also, it's important to remember that not everybody, I'm sure, again, all delegates will be aware of this, but not everybody's great at having these kind of long, verbal conversations, really. And sometimes just, that's one way of supporting someone, which a lot of us find helpful, but not all of us do. And just having that personal contact, even if it's doing an activity together, for example, like going for a walk, or gardening, or whatever it might be, just doing that activity with another person can be incredibly grounding. And I just want to touch on one other thing that there's been lots of reporting, I think, in the news, and we're all aware of this risk about people who are isolated becoming almost kind of extremist in their views. There's this kind of worry about people falling down, social media kind of rabbit holes and getting into sort of paranoid states of thinking from that. And I think, as well as protecting our mental health, being around others, and also around others that might see things differently or might disagree with us, helps protect us from getting into those escalating spirals where we can become quite paranoid. All of us, if we are isolated, or can be vulnerable to developing these kind of paranoid mindsets. And the way to protect against it, in my view, is to make sure that we continue in contact with people, including people that see things differently to ourselves.
Well, I think that what we were saying before about meeting people and going for a walk, I mean, that at the beginning when we were in complete lockdown, I think was well, it was a lifesaver for many people, but there were people who couldn't get out, people who
Mm.
are not able to go for a walk. I'm hoping now that, because lockdown is not, well, we're not locked down, but we're still in this crisis,
Mm.
um, the fact that more people are able to meet. But
Mm.
what I'm worried about, as I'm sure we all are, because there's a kind of pattern, this 3 and 4 months pattern, and there people are still talking on the news about there being possibly a fifth wave.
Mm.
I mean, that's really, I think it's quite terrifying. And you've talked to me about that there was a pattern with COVID, a sort
Mm.
of 3 to 4 month pattern. Can you just sort of expand on that a bit?
Yes, yeah. I mean, I won't say too much about it, but I'll just touch on it. I'll touch on it briefly, I suppose, which is, I think we're facing now the is the reality, which I think most in the medical profession and the world of kind of epidemiology and public health accept, which is that COVID is here to stay. Essentially, it's not going to go away. But, and I th- I feel there was a bit of, I think, kind of magical thinking at one point, maybe, that it would just go away, if we all behaved in a certain way, and that's apparently clearly not going to be the case. And what I suppose what I would say, which I think is helpful for us to be aware of, which is that it can be quite tempting to get into a position where we think, well, if only we all behaved in a certain way, that this problem wouldn't exist. But similar to how a psychiatric illness and mental health difficulty is never just the result of one individual factor. It's never one grief or one loss or one incident that leads to psychiatric illness. It's always much more complex than that. I do feel, and this is, I think, fairly consensus view in the medical profession, that this is the case with COVID as well. It's never going to be, you might see in the news, oh, if only we did this one policy, then everything would be better. And that's not the case. It's complex interaction between human behavior of the virus, behavior of the environment. And our behavior is, of course, we have an ethical responsibility to look after ourselves and not harm others, of course, but that is just one part of the trajectory of this virus. But as we move forward, I think it's really important to keep coming back to principles of risk assessment, which we haven't talked about this morning. So maybe I'll just quickly touch on that, which is it's really important to keep reevaluating your own risk and the risk of people around you, and not make the same assumptions that because of what the risk was 18 months ago, that risk is the same now. So, for example, it's really important that when we take steps to reduce our risk and the risk of people around us, that those steps that we take are proportionate to what the risk actually is, and that those steps are also do actually reduce the risk. So clearly there's no point taking steps which don't actually make any difference to the risk. So an example of this is if we think that, we now know that the risk of transmission outside is pretty low, thankfully. So therefore, there's not much point in avoiding outdoor situations because the risk there is already very low. So I would actually encourage bereavement visitors, where they feel confident, to help people who are struggling with re-engaging with the world, to help them think through their risk. Because sometimes it can feel very overwhelming. I think we're all prone to, I know I am, prone to catastrophizing. We're thinking about the worst possible outcome. And it can be very helpful just to have someone else help them talk through. So what actually is the risk? What are you scared of? What can you do about it to reduce that risk? And is what you're doing actually going to reduce the risk? And finally, is it sustainable? Because we're here for the long term. So I think saying that one says, I'm going to feed myself kind of indefinitely, well, I don't think that's particularly sustainable. I think there are some people who have underlying health conditions who may need to do that, who may be in positions where they need to do that from time to time. But clearly none of us can live like that in the long term. And I think we have to be very kind of explicit about that.
I think that's right. Yeah, no, it does completely. And in fact, I think what you were saying about telling people to reduce the risk, I mean, I still know people who won't go out, who won't mingle with even in a restaurant, or they'll just about do gardens still. And I think also we expected it at the beginning, as you said, to be a finite thing. We've got coronavirus, we're going to get rid of it, and then we're all going to be better. And that clearly isn't the case. It's and we're going to have to learn to live with it. But I think it's trying to get those people to understand that. The people that can't move on. And of course, if you're in grief and you've just been bereaved, you've got that to think about, and then it's thinking about all the other things at the same time. I think that's very difficult.
Yeah, I think something can be very helpful in those situations is and this is what I mean, I suppose, about meeting with people who see things differently. It's so important. And as professionals or bereavement visitors or people who are supporting people in any way, something that's I find very helpful is to really understand things from, underlying any difference of opinion or any views about this is coming at it from a perspective of compassion and empathy. So and really putting into words what their experience has been for them, to show that you've heard their perspective, and then offer another perspective, and then maybe together you might find some problem solving. So for example, I might say to someone something like, I can really understand from your point of view, how frightening it is. There's this terrible virus, and you may have lost somebody, and it's so frightening, and I understand why you may be very, very reluctant to go and meet people. And so they really understand that you've heard that position, and then you can also say, also I'm thinking about how we have to be able to do things which are sustainable and available in the long term, and then together be able to maybe problem solve a bit. And if it's not possible to do that, then I think just sitting with someone and keep coming, supporting them and maybe coming back to it in the future if it's appropriate.
Yes, and I think listening, you were saying, is what I also said about listening to the silences and
Mm,
letting somebody just sit there with someone, which is much harder when you're doing it over a phone.
yes, yes.
Um,
Yeah.
and certainly not all of our visitors are seeing their clients face to face.
Mhm,
Well, I'm certainly not. As I said before, some people prefer it on a phone, but
mm,
it's really very difficult. And that's certainly what most bereavement visitors aren't trained to do telephone bereavement visiting, whatever.
mm,
They're not trained to do that. They're trained to be sitting with somebody, and that connection makes it easier. And you can listen to somebody or not, or listen to them cry and weep gently. On a
mm.
phone, it's very hard. But
Yes,
it's all about human connection, isn't it? I mean,
yes,
I
yeah.
think getting better and helping our visitors and helping our clients to get through it. But in your experience, do you have certain groups within society that are sort of react differently? Is it socio-economic? Is it faith groups? Is it, I don't know. I think that would be very interesting for our visitors to know that.
Yes, yeah, that's a very good question. So, through working in NHS mental health services, I have the privilege, and it really does feel like a privilege, of meeting people, of course, across the whole spectrum of society. And in the work that I've been doing over the last 18 months has also included home visits. So I've been going to see people in their homes. And definitely there has been a huge difference in responses. Of course, within each community, there'll be also the whole spectrum of responses, and we should never make assumptions about an individual's response, depending on whether they're in the community, which community they're in. But I would say that certainly, so when at one point in the last 18 months, I was working in a crisis team, so with younger adults, and certainly with some of those individuals, um, they they weren't able to respond to the lockdown restrictions in the way that others were. So, for example, if you have perhaps a severe mental illness, or even if you don't, but you live in a crowded kind of supported accommodation, and maybe your home isn't very nice, and you're unhappy about that, and you don't get on with your housemates or whatever it is, then I was meeting people in these situations, and the idea of just staying at home and not going out it just didn't make sense to them. It wasn't really a thing that was possible to do. So I would say that some of the guidance that was issued from the government kind of went over their heads. Essentially, it just wasn't something that people in those environments could do. And I think we have to look at that from a place of understanding. If I was in that position, I too probably would have found it very hard just to stay at home and stop doing all the other activities. And then religious groups, yes, I mean, so yes, I have seen the whole spectrum of responses from religious communities that have taken on board the ethical obligation of reducing any risk to health or life, and therefore have been very, very cautious, understandably so, to religious communities that sort of feel that, well, we already have our own structure for dealing with grief and bereavement, and our community structures are more important, so have kept things going, perhaps not in line with the guidance. So I've seen that whole spectrum across faith communities, across economic backgrounds. Yeah, I think we have all responded differently. And I'm sure we've all, as well, individually, will have our own feelings about that. Within our own communities, some of us will feel like, oh gosh, I wish my community or people around me were more careful. Or some may feel like, gosh, I wish my community had kept these things going because I really relied on it, and I'm suffering now, or other people are suffering now.
All right. Thank you. And I'd like to now open up the questions and answers. Forgive me if it looks like I'm reading my phone or playing with I am reading my phone because I've got the questions here. This is questions from our delegates, please. This is from Pippa in Northwood. With all these problems, how difficult is it to access further help on the NHS?
Hmm. Yeah, so thank you for the question, Pippa. I think it depends on what type of help you're seeking. So, for example, in the memory service where I'm working part of the week at the moment, it was closed for the memory services was considered at one point non-essential because it was felt people could wait for their diagnosis of dementia, for example. And so for a short period of time, the memory service stopped doing assessments. It's now fully, and then for quite another period of time, we're only doing video assessments and only home visits if there was a very immediate risk. Now we've gone back to functioning pretty much normally, so we do all home visits. So within that particular service, it's very possible to get help at the moment, and the wait time is short. However, for other areas of mental health services, for example, in eating disorders, there are huge wait lists, and the service delivery has not been able to keep up with the demand. So it really does depend on which bit of the NHS you're wishing to access or someone needs to access, on kind of what that service delivery is looking like. And then the other thing to say is that, as well as sort of the wait times, and I know I touched on this before, there's also something about what that service actually looks like. So most community mental health services are now picking up in terms of what's being offered. So, for example, in the older adult services, the older age day program is now functioning, the dementia cafes are functioning, the dementia, all the home visits and carers groups, they are now up and running. So that's positive. On the mental health wards, so for people admitted to psychiatric wards, there was a period of time where the actual treatment that was provided on the wards was quite stripped back. So, for example, the group programs were stopped for understandable reasons. But what was more challenging was that people were being asked to isolate in their rooms for a period of time when they came to the ward. That was, of course, incredibly challenging, because if you're in a mental health crisis, of course, being in isolation in a room is probably not the place you wish to be. So, in terms of the NHS's kind of ability to respond, I would say it's complex, and will depend on which bit of the NHS you to access, what the level of severity of illness is. Take-home message, though, is please do not sit on anything. If you need help, do go see your GP, or do seek psychiatric services if that's what's necessary. We are here, and we're here to help. So please don't just sit on any difficulties, or if people you're supporting have difficulties, please encourage them to seek help as well.
Yes, I can understand that there's a reluctance for people to approach their doctor at the moment because they feel that because we've all heard the strain that the NHS is under, that they're not going to get heard. So that, I think that's a really good message to put out, and for us to encourage people, and our visitors and our clients.
Yeah.
Question from John Spencer. What is the role of facilitated group support?
Oh, yes, good question, John. It's an interest of mine as well. So groups, I think, are absolutely one of the, in my opinion, is one of the most helpful ways of providing mental health support. And I think there's a few reasons for this. So pretty much all mental health difficulties, whatever form, in some way are rooted in our relational lives, our relationships with ourselves, our relationships with people around us. So by being in a group, you are an individual is able to explore their group relationships, their relationships with themselves, relationships with people around them, in a much more sort of three-dimensional way, I think, than is always possible in one-to-one work. Clearly, I don't mean to undermine one-to-one work. That's also obviously very important as well. And some people may not feel able to go to a group or not be willing to. But group work is very helpful. And actually, when you look at the accounts of people who've had severe mental illness, who've been through the psychiatric system, I'm always struck by when you kind of read autobiographies, for example, or blog posts or whatever it might be. very, very commonly people will say one of the things that was really helpful was the relationships with other people on, for example, on the mental health ward, and the things that other people on the mental health ward said to them and helped them recover. And it's always striking to me that that's really often the case, that people will talk about those people, perhaps even more so than an individual psychiatrist or nurse or mental health professional. So that can, and I think it's often the case that we, in groups, we can say things, peers, for example, or carers, can say things to one another in a much more kind of blunt, maybe and open way than a professional may feel able to do so, because they may, don't want to come across as being judgmental or I don't know, overly opinionated or something. So I think, yeah, group work is really, really positive. And there are, of course, has been harder to find group work during the pandemic, but groups have functioned online and do function online quite well. Probably more smaller groups, less if you want a really kind of good group discussion, probably less than 10 people, I would have thought. But yes, groups can function online, and we are really lucky with our Zoom technology to be talking about groups.
Yes.
Yeah.
And I suppose also the people in the group can relate to other people because they are, if you like, ordinary people. They're not professionals, and so they can see somebody else as and I don't like to use the word ordinary, but an ordinary normal person sitting
Yes.
next to them is also having some kind of crisis, more relatable than perhaps to the psychiatrist who is slightly on a pedestal.
Yes, yeah. And there's this idea in group psychotherapy, which I find very helpful, which is that whenever anyone expresses something in a group, and you can think of this in a therapy group or support group, but also any group that we might exist in, a family, a team, workplace, community of some type. Whenever anyone expresses something in a group, they are expressing that on behalf of themselves, but also on behalf of others. So that if someone is particularly angry about something, it's likely that there are other people in that group who are also angry about that same thing but haven't felt able to express it. So it's
Yes.
very helpful being in a group, because you'll see things, you might be there as a group member and have felt unable to put something into words, and then someone else kind of does it on your behalf. I mean, it's really quite profound, I think.
Yes, I'm sure that must be. Thank you. Um, can you say more about psychiatric illness as a prompt for understanding society apart from paranoia? That's from Catherine Staff.
Yeah, thank you, Catherine. So, yeah, so there's this idea. Excuse me if I talk in a little bit kind of academic language, but there's this idea in group psychotherapy of the social unconscious, and what that means is that there are societal dynamics, and histories and legacies and things that have gone before us, which are still being played out all the time. And so, for example, an example of this might be perhaps, for example, racial injustice, for example, or perhaps inherited trauma of some type, that we've all these things that have gone in the decades and generations before us, and they're still being played out in some way. Now, if you are existing in a fairly kind of stable and maybe economically secure life, where you're not encountering particular distress every day, or your needs are kind of met, then maybe these inherited histories might not come out in the forefront in your daily life. They're just kind of there in the background. You might not think about them very much. But when you reach a crisis of some type, and psychiatric illness is one of those times when you have a crisis, then suddenly these things can become very, very obvious. And so, and I would consider psychiatric wards, for example, mental health wards, to be one of those places which perhaps you might say are a marginalized area of society. Maybe they're somewhat on the edge, but that is somewhere where these inherited histories and things that happen in society become very, very obvious in psychiatric wards. So, for example, that might be the fact that on psychiatric wards at the moment, there's a disproportionate detention, so sectioning of Black men, for example, might tell us something about racial injustice that's happening in society. Or the ward where I work at the moment, an old age psychiatry ward, we have out of a group of 15 patients, 2 or 3 patients who are Holocaust survivors, and then who've been living their lives without need of mental health services throughout their life. And then as they've got into an old age, these problems have come to the forefront. So, so as well as those individuals needing to be supported in their own terms, clearly, I think that we can learn something from these areas of society which are maybe somewhat more on the margins about what is happening more generally around society, which we may struggle to notice some of the time. If that
Thank
makes
you.
sense.
Yeah, makes sense to me.
Yeah.
I hope it makes sense to the person asked the question. A question from Richard Conradi. What's your view on how angry many months after a death bereaved people can feel that loved ones didn't get help for cancer but were busy with COVID? I think that's just come up, an issue that's come up quite a lot.
Yes. So can you repeat the question? How angry someone might be?
Sorry. Your view on how angry many months after a death bereaved people can feel that loved ones didn't get help for cancer because things were busy with COVID.
Yes, yes. I mean, I think that so anger which persists in that kind of way, as is described in that question, in my view, there's something there about it not having been possible to find a resolution to that anger. So in normally when we are angry about something, we would find, I suppose, the task for an individual or someone supporting an individual is to think about, okay, how can we down regulate that anger? How can we help think it through, and help process it and recognize the circumstances that led to it and be sort of sad and unhappy about that, maybe do something productive with it and sort of move forward. And I think it's probably very hard for people to do that at the moment for a number of reasons. One is that we've been constantly, so if it's the case where services were closed and therefore or were not as responsive as they previously were, so therefore cancer diagnosis was tragically missed. We are being constantly reminded of that all the time because COVID is in the news all the time. So maybe it's that kind of PTSD thing we are talking about before, kind of repetitive reminder. And then the other thing which really helps deregulate anger is being in relationships, meeting people, being able to be in community, and we don't rely on other people to downregulate us. And so if we're not able to access that either, then I think that anger can remain very, very prominent. So I can understand why someone might remain very angry for a very long period of time in this current climate, and maybe having this kind of conversation with someone about, I can understand why you'd be so angry, particularly when you're reminded of it all the time, might be a helpful conversation to have, perhaps. And yes, and I suppose, people will reach that stage of being able to move on from an anger. That's going to be unique and different to each person. I'm just going to draw the blind down because I've got the sun in my.
Okay. I'm going to look at my phone. I have another question from Sharon Smith. She asks if there are any tools that you can give us to recognise the need for psychiatric support for complex grief.
Yes. So thank you for. So I don't have any sort of tools in terms of a questionnaire or tick box, but a really important question to ask oneself with regards to if we're thinking someone might need more specialist support is that question about day-to-day functioning. So if somebody is not able to do in a sort of significant way, obviously it's a normal part of grief that you might withdraw from certain areas of your life, but if it's reaching a stage where for example, they're not able to keep on top of their administration or their finances, or aren't able to do the shopping, or their home is being neglected, any kind of risk in that sense. And it doesn't have to be, risk like you're worried that they're going to come destitute within the next 24 hours, for example. But, something about just not coping. And if that goes on for a period of, I would say, kind of more than kind of 2 to 4 weeks, probably 4 weeks plus, then you would, I think, probably, I would suggest to someone that at the very least they go and see their GP, and the GP will take it forward from there.
Okay, thank you. Carol Binish has asked behavioural difficulties regarding dementia and also OCD, the autistic spectrum, whose world has changed. How can we support them?
Yes, yes. So for people with dementia, I mean, we've spoken about this already. It's such a hard time. I mean, it's hard to even, I think, put it into words sometimes for the difficulties people with dementia and for their carers. Carers. I know I'm saying this to people already aware, but I'll say it anyway. Carers just, in order to care for somebody, you have to have time where you have time off from being a carer and you're able to look after yourself. It's not possible to care for someone 100% of the time. And during those periods of lockdown, people were put in those positions where they were caring for people with challenging behavior, for example, all the time. It's just an impossible position for anybody to be in. In terms of how to support, so what there's a sort of principle in assessing people with dementia who are having perhaps challenges. There's this principle of looking at the what can be done for the individual with dementia, what can be done for their carer, and what can be done for the environment in which they're in. So for the individual, it might be things like um, uh, aggression or so I don't want to talk too much about aggression because I don't want to sort of stigmatize people with dementia, but if there's this kind of difficult behaviors or things which might be hard to cope with, if it's very helpful to get a sense of where they might be coming from the perspective of the person with dementia. So for example, if it's coming from a place of feeling disorientated and lost, then there are some very simple things you can do, like put a dementia friendly clock it's visible for them to see, or something of that type. And then thinking about how to support the carer. I mean, often that's going to be around making sure the carer has breaks and has support perhaps with other carers. And then the environment is things like making sure the environment is appropriately set up, the home is safe, if they have access to good quality nutrition and sleep and all of those sorts of things. And I think you mentioned with what was it, OCD and autistic spectrum disorder. I mean, I think it's very, very similar. I mean, people have had a really, really hard time with their routines being disrupted. But I think we can now I think we are now in a position where we can help people rebuild their routines and have some confidence that those routines will be able to be continued. I very much hope so anyway. I think probably the support will be mostly around that. It's really similar principles, trying to get the person to be able to do things which they enjoy doing, where again they meet with other people in a way that they're able to do so, and crucially that the carers around them have some time off, and that we all are able to, whether you have dementia or autistic spectrum disorder or OCD, or you're a carer, that you have multiple roles in your life. It's just so important where you are both caring and cared for, and also are a family member and a community member.
Thank you. Sharon Goldstein has asked that you answered about anger many months after a death, but this initially is if you're talking about somebody who has had cancer, whose family feel that they were neglected by the NHS, and that resulted in the death of the person. Can you expand on that at all?
Yeah, well, just to say, I mean, first of all, I imagine this might be about someone in a particular individual. I'm not sure, but I'm sorry to hear about that. And I think there has been a lot of attention on this issue as well, about how some areas of a health service were difficult to access during the period of lockdowns, and is now sort of catch up. I mean, I just think it's an awful situation for an individual to be in, or family to be in, and to be constantly reminded of it. Of course, with the news, as I've spoken about. I think it's and anger can be a helpful emotion to drive us to problem solve. And I know this. I think that's true for all of us. There's certainly things which I've got involved with from a position of anger. It's prompted me or motivated me, to take a particular action or campaign or join a particular group. And so I would probably encourage, if it feels like this is an anger that isn't that's coming from a place of injustice, perhaps, or a place of something negative happened which shouldn't have done, then I think it's helpful to see if can that anger be put into something which helps move things forward. So joining maybe other people, if there's a group of other people that have been in a similar position who maybe want to campaign to make sure that such a thing doesn't happen again, or to make sure that that complaint is heard at the NHS level, and that the complaints are appropriately processed, and if appropriate, met with the clinical leads of whatever services are responsible. If I always encourage that, and I'm actually surprised how many people don't do this. But when people do feel that they've experienced an injustice of some type from the NHS, I always encourage people to make a formal complaint. It's something there's very rigorous complaints procedures in place in the NHS, and sometimes they're not used. So if that's not been the case, you might want to suggest to someone that perhaps they can make a complaint and take it forward in that way.
Yeah, I think making a complaint sounds a really good idea to focus your anger, but it can also be the most frustrating thing. There may be a procedure in place with the NHS, but it's a very clunky procedure. So I think that, but I like the idea very much of focusing your anger as a positive thing to prompt you to do something. But I can see how that could, because I think when you get into the that sort of going backwards and forwards with complaints, it's all consume. It can be all consuming and can be very negative, I think.
Yes, it's helpful to hear that, Judy, because I've not been on the complainant side of it. So it's very helpful to hear that
I
perspective.
have. It didn't work. So I think it's a very difficult. The NHS is a very large organisation, as we know, and it's difficult to get that moving. And I think the frustration that people get into a big spiral.
Yeah.
But conversely, it could be very a positive thing to focus your anger on that.
Yeah. Well, thank you for saying that. I mean, I think that would be something that you could be mentioned. That these are perhaps try to help someone think. Where can that anger be directed? One of which would be a complaint thing, and then you could say, well, look, there's positives about that and negatives, and or could that anger be go somewhere else? And help someone kind of think it through. Really.
Yes. I think I was seeing it from the negative angle, but I can also see how the positive angle could work. And how do you look after yourself, which is a question that how do you look after yourself after a difficult day?
Yeah, well, I have to say, I feel very, very lucky as a psychiatrist and as a NHS worker during these last 18 months. And the reason I say that is that I feel like my position my professional position has been very protected during the period. I guess it's a privilege of being classed as an essential worker. It's meant that I have been able to go into work in person throughout, and I was very pleased to be able to do that. And I know that I have certainly have colleagues who felt differently. And I probably would feel differently if I was living with an elderly family member, for example, where I was worried about bringing risk home. But I'm not in that home situation. So I felt very, very lucky to be able to go to work in person while so many other people were facing isolation. And I also feel lucky to work in the mental health part of the NHS because I feel that the mental health bit of the NHS has got certain structures in place which I think are, to be honest, lacking in other areas of the NHS. So those structures are things like we still have stable teams where I know who my colleagues are and they're not just going to change from week to week, which does happen in other areas of acute medicine, for example. I've had excellent supervisors who I meet with regularly, and I have a really wonderful peer group, and we meet online, but monthly for a reflective practice group, which is hugely helpful, where we've been able to talk about some of the issues really that we've spoken about today and other issues as well. And then for me, the other thing which I find I think, well, I suppose it's a double-edged sword. I feel it's quite protective for my mental health, but also causes some stress, which is that I'm a chair of my synagogue, and I suppose that comes down to what I do feel that having community relationships. I know I've mentioned this several times, but I think having community relationships outside of your friends and family is incredibly protective for your mental health. But it can also be a source of stress because it means you're forced to meet with people who see things differently. And when you are working on community projects together, it's different to just having a friendship. Those differences and disagreements are brought into the forefront because you're working on something together. But I think that's helpful. I think that's helped for me. I think it's helped ground me and perhaps helps reduce the risk of getting into these um, thinking spirals. I think some of us are prone to, and I'm prone to as well.
Well, we're coming to the end of this, but it's very interesting because you've just answered the question that I was going to ask you, which was from Anne Marie Wilson asking about the impact about being in a faith group. And I think you've just answered that. Thank you. And I've really got to finish off now. Just generally a question. What made you want to specialise in psychiatry?
Thank you. Yeah, thank you for the question. So I actually started, before I started training in psychiatry, I started training in acute medicine and diabetes and endocrinology, and then switched into mental health. And the essentially it was quite a simple thing. But when I was working in acute medicine, and of course we had patients with mental health difficulties who would end up on medical wards in some way, or people on the medical wards would develop mental health difficulties. And we would call the psychiatry team for help, and they would come and see those patients. And when they came, I always thought to myself, I'm more interested in what they're doing than what I'm doing. So maybe I'll stop what I'm doing and train in what they're doing. So that was really my route into psychiatry.
And how long is the training?
So it's so you have so your medical school, and then you have junior doctor training for a couple of years, and then if you go straight into psychiatry, you do 3 years of what's called core psychiatry training, and then 3 or 4 years of specialist psychiatry training. So that's about 7 years of psychiatry training, and I'm now in my seventh year of that.
Right, okay, thank you. Well, I think that really sums up what an experienced person you are and the knowledge you had. Very, very interesting. I hope I hope our delegates enjoyed listening to you and got a lot out of it. I certainly there's a lot to think about. One thing that struck me very much was your talk about anger being the positive, and it isn't something I'd really thought about before. And I think that's something I'll take away that I'll be able to put to my clients. So very useful. So we're now coming to our short intermission, as they used to say. There will be an interlude. It's going to be about 20 minutes. There will be a small presentation. It's about 10 minutes long, so it's going to be going around twice. So you'll have plenty of time for getting up, comfort break, getting coffee, etc. Thank you very much. Thank you again, Rob. Absolutely fascinating. And I look forward to seeing the rest of you in about 20 minutes. Thank you very much, everyone.
Yeah, I just want to say thank you very much, Judy, and thank you for the invitation as well.
You're welcome, Rob. Thank you. It was really interesting. Thank you very much.
No.
No, hang on.
Welcome back, everybody, and I hope you enjoyed our short film during the interval there. I'm sure you've been aware of all the conferences over the years and what a range of topics we've covered. I'm hoping that maybe some of those topics, if you were not part of our earlier conferences, have given you some ideas of things that you might like to see in a future conference. So please do remember some of those titles and do use them in our feedback sheet that will be coming through to you in the next day or so. Now, we've just sat through an amazing hour with Dr. Robert, and we've had lots to think about there. Empathy and agency are two words that spring straight to my mind, and facilitating that sense of control and choice making with our clients. So now we're going to have a slightly different perspective on the long journey through COVID. When we were planning this conference, we realised that everybody working in different spheres had very different perspectives on COVID, partly due, as Dr. Roberts said, on the fact that we were quite closed down and we were not mixing and mingling, and we weren't able to actually see what was going on in different settings, whether that was a school or a church or a synagogue or a hospice or a clinic. So we are absolutely delighted to have Reverend Giles Pinnock and Sharon Merchant with us next, both of whom have worked in very different settings during COVID. And they're both hopefully going to present their perspective of their journey through COVID in their settings and the experiences they've had with their patients or parishioners or clients. So without further ado, we are absolutely delighted to welcome Father Giles Pinnock.
Yeah, hi Angela, thank you, and thank you for the invitation to speak today. So I'm just going to share my screen in a second, but before I do, just to give you some background about me. I'm a Catholic priest, and I am the chaplain at the Imperial College Healthcare NHS Trust, which is a large acute trust in West London. Our main sites are Charing Cross Hospital and St Mary's, and the Hammersmith Hospital, or the Hammer as we call it. We also work with some private hospitals, with HCA, which is Healthcare America, who run several sites in Marylebone. And we also do work with the Bupa Cromwell Hospital. So we're quite spread out, and we're a team of about a dozen chaplains, working across private and NHS settings, across acute, every specialism, stroke, respiratory, which obviously is a particular relevance to COVID, as is intensive care. And we have had a very, extensive experience of COVID. And yeah, so that's me. I'm now going to start my presentation, and I will try and keep to time. As I warned the organisers before, I'm quite good at completely forgetting about my slides and going off on one, but I'll try very hard not to do that today. Okay, so I'm just going to share my screen. Okay, which one is it? Okay. Share. Okay, so I hope you can all see my slides. So it's a long journey from the perspective of hospital chaplaincy in particular. So the first thing, when I saw the title, it reminded me of a conversation I had many years ago with another priest. And I think we'd been at a deanery, a local clergy meeting. And somebody had been talking a lot about being on some particular journey of faith. And as we came out, my fellow priest said to me in a slightly exasperated fashion, "Why is everybody on a journey?" And I think he was voicing a certain kind of exasperation with what he felt was a slightly cliched metaphor. And maybe it is sometimes a bit cliched to talk about everything in terms of a journey. But actually, I do think that when we're talking about bereavement in particular, journey is quite a good metaphor, both as the journey of life, which of course comes always for all of us, comes to an end with death. But also it's a series of journeys, and one of those particular journeys within life is the journey of bereavement. Now, journeys as a thing have first steps, they have intended destinations, but as we probably all know, all journeys, whether it's the journey of life, the journey of bereavement, the journey of driving to Glasgow, there's always a potential for diversions, for unplanned stops, for changes of plan, and even changes of destination. And actually, in some ways, that's a very important point, I think, that when we are dealing particularly with bereavement in the context of the journey of life, is that at the moment, here I sit here at work. I'm, as far as I know, pretty healthy. I'm 54 years old. My father lived till he was 90. My mother's in her mid-80s. In my mind, my destination is probably several decades down the line. I don't know that. The destination might change. I might walk out in front of a bus, or I might get a life-limiting diagnosis next week. So the destination might change. And that immediately reconfigures my sense of the journey I'm on. And that is the context in which grieving, bereavement very often happens. So just moving on to the next slide, and just thinking for a minute about that long journey of bereavement. It's a journey that everyone is destined to be on. And yet it's one of the most private and undiscussed and possibly the loneliest. Now, we've had quite a lot of input already specifically about COVID and the loneliness that many people have experienced in the context of COVID. Now, one of the things about my presentation is I've tried quite hard not to focus entirely on COVID. Because although, yes, it's setting the context for a lot of things that are going on around us at the moment, the journey of life, the journey of bereavements were happening before COVID, they happened during COVID, and they will carry on after COVID, whatever after COVID means. And so I think it's really important that we see COVID perhaps as, in some senses, one of the steps in the journey of our lives. We see it as one of the bereavements, and it is a bereavement. We've had a cultural bereavement, in the sense that I think before COVID, we had a very strong sense of almost a hubris as human beings, that actually we could control just about anything. And suddenly we found out, maybe we can't. Now, there's an argument to some extent that there's a feedback loop going on, in the sense that the more we tell ourselves that COVID changes everything, the more we allow COVID to change everything. So I think we have to, be very aware of the effect COVID has had on us, but also to be aware of the journey of life, the journey of bereavement as something that happens to all of us, will happen to all of us, and yet we don't always discuss it, and we can be very lonely in it, however much sometimes we talk about it. Bereavement isn't quick, and it's not easy, and there is no magic wand or quick fix. Some people do it better than others, or at least they appear to do it better than others. And some people get stuck. I remember in Robert's talk, there's the picture of the people on the bridge, and somebody chained to the ground on one end of the bridge, and a sense of just can't move on, or maybe somebody dithering in the middle of the bridge. And people do get stuck, and some people seem to sail through it, but do they really? And certainly from the perspective of a hospital chaplain, as I'll say in a minute, that we have a particular perspective on that. Now, bereavement takes time, and there are ways of understanding it, and we saw on Robert's slides the Kubler-Ross model, the stages of grief. And looking at those stages of grief can help. It can help frame the experience we're having. One of the lonelinesses of bereavement can be the sense of, this has only ever happened to me. How can anyone understand how I feel? And I know others have felt this, and I've certainly felt it myself, that you have somebody close to you die, stay in hospital or wherever, and it's maybe at 2:00 in the morning, and you have to talk to the nurses, and then maybe the priest comes, or your minister, or whoever. And at some point you have to leave. At some point you have to leave the ward, you have to leave the hospital, you have to go down in the lifts, down out to the car park. You have to get in your car and drive home. And as you do that, you realise that the rest of the world has got the incredible cheek to be carrying on as if nothing's happened. And yet to you, the world has changed, and yet the world doesn't acknowledge it. And that can be very alienating as a general experience, I think, in people's experience of grief. But, so in this sense, there's two ways in which I've kind of departed from my brief already. One is that I'm not going to focus too closely on COVID as a particular thing, but also thinking about bereavement and from the perspective of a hospital chaplain. I think if there were one word that I would use to describe bereavement care in the context of hospital chaplaincy, it would be immediacy. Now, what do I mean by immediacy? I mean, very immediate. It's not about this long journey that we're talking about. It's about something very momentary. So again, that seems to a bit fly in the face of the brief that I've been given. So I'd just like to ask you to bear with me so that I can explain. And I'm going to do it in the metaphor of, which is personal to me, of going to a new parish. Now, I mean, at least one person here I know knows what it's like when I turn up as the new parish priest. Most of you don't, but at least one person here does. And certainly what my experience, and I think a lot of priests feel like this, is that when you turn up in a new parish or a new appointment, there's a sense of, who is this new guy? And people look at you a little bit askance. They look at you out the corner. Why have we got this one? What was wrong with the last one? Why have we got a new guy? Who is this person? And in that situation, then perhaps there's quite a lot of work to be done to build up the trust and the relationship that enables you to help people with the big moments of life, with their bereavements. Now, this has happened to me, where almost the first thing that happens when you turn up in a new parish is that there is a big funeral, a big parish bereavement, and you almost have to get that one right. But as a general rule, it takes a while. It takes a while for people to get to feel comfortable with you and to trust you. It's a question of trust, and you have to play the long game. You have to gain trust. You have to do quite a few baptisms. You have to do the marriages in families. There'll be the deaths, and then there'll be the home visits. And that's perhaps when you start learning a little bit about your new parish, your new parishioners, how they are dealing with that bereavement. But as I'll talk about a little bit more about later, certainly in the context of the home visits, you realise that almost immediately that actually you're not just dealing with the bereavement in hand. You're dealing with something longer, with overlapping bereavements, with bereavements that have gone on for quite some time for some reason, and that you are becoming involved in things that happened long before you were there, and things possibly that will carry on long after you leave. So I think personally, it takes at least a year as a new parish priest to be able to go into somebody's home to talk about bereavement and for them to be really open with you. You need to have earned the trust. However, in a hospital setting, it's quite different. If someone's been given a life-limiting diagnosis or someone has just died, there's very little time, very little time for that getting to know you time of gaining trust. Many of the time I've gone to see somebody, I've been asked to go and see somebody because it's felt that chaplaincy would be helpful. I've sat down beside the bed and I've said, hello, I'm Father Giles, I'm from chaplaincy. Angela from palliative care asked me to come and have a chat, if that would be helpful. How are things? Well, will come the answer. I was told this morning I've got 3 months to live. And you are thrown right in. It's very, very immediate. There's no flannel, there's no smoke, there's none of the looking slightly askance that you can say, well, why have I got this one? You're right there in front of them, they're right there in front of you. The situation that they are in has been put squarely in front of both of you. And it's hard to avoid it. It's right there in front of you. Or alternatively, and sadly this is too often the case, that people who don't get referred to chaplaincy even during the latter part of their lives, and the first contact you have is with the family at 2 o'clock in the morning. And again, it's very, very immediate. There is no getting around why you're there and why they're there. There has been a death, there is a bereavement. And however well they may have been prepared, in at least in theory, for that death, it may be that the illness has been going on for some time. It may be that they've had lots of time to talk about relationships within their family and funeral arrangements and all of those things. They may have felt very prepared. And yet when the death comes, it's always a whammy. And it's always very immediate. And you can't make small talk. It's very much there. So that's a really big, I think, contrast between a lot of the relationships we have as priests, and indeed chaplains and lay chaplains, outside of hospital. They are in the context of long built-up relationships and understandings, and whereas in hospital they are immediate, not to say abrupt. Sorry, not to say abrupt. You may have had those few visits to the patient. Very often we are called in too late. It would be nice to talk to them when they were more able to talk with us about how they felt about their situation and their impending death, their sense of bereavement of their own selves. So maybe they were expecting to walk their daughter down the aisle in 6 months' time. Maybe they were looking forward to grandchildren, and yet that's now all been taken away. So there's a bereavement of self, even with somebody who's not died yet. But then also there's the half hour, the hour with the bereaved at 2 o'clock in the morning. Sometimes, in the context of being a hospital chaplain, we will also have contact around a funeral. Many of the people here probably realise this, but as hospital chaplains, we are, in a sense, the funeral providers of last resort. And what do I mean by that? I mean that we are brought in to do the funerals, typically very minimal, quiet funerals in crematoria of people who do not have family or friends to make an arrangement, or maybe there aren't the means to pay for it. And then it falls to either the hospital or the local authority to pay for the funeral. And we are brought in very often with very minimal contact before and after in order to conduct the funeral. So it can feel very abrupt and very short term. And in many ways, chaplaincy doesn't usually extend very far beyond the hospital doors. They leave and maybe there is the funeral contact, but they're not very often, they're not. So we are talking about bereavement in general, from whatever, from COVID, from cancer, from whatever. And our involvement is very often episodic. It feels very episodic. We're one step in the journey, one episode in the journey. So maybe they're on this long journey to Glasgow and it starts raining. Well, we hold the umbrella for a bit, but then they move on. So in a sense, what can I contribute to It's a Long Journey if my involvement, if my perspective is so sort of episodic, so short, so abrupt? Well, I think we have to put all bereavements in context. And one of the contexts is that this may not be their first significant bereavement. They may now be arranging the funeral for their mother, having done so for their father 10 years before. There may have been, and this is one of the most unspoken bereavements, one or more miscarriages. That's one of the most private griefs, I think, that we have contact with as hospital chaplains. And, we may hear a bit more about that in the next presentation. But certainly that context of bereavements overlapping one another, rolling on, one into the other. So I remember going to one quite early on in my ministry as in a parish and being quite sorted in my own head about what we had to arrange and having been quite well briefed by the parish priest about the family, about the situation, etc. So I went into the house and I sat down. I said, okay, I'm very sorry for your loss, all of those sort of things, and started talking about the funeral, which was scheduled for about a week hence. Almost nobody in the room could talk about that funeral. They were all talking about other funerals, other bereavements, other things that had happened. And I kept having to try and pull them back into talking about this one, or at least that's what I thought I had to do. And yes, we did have to arrange that funeral, but I became aware then and down through the years that very much each bereavement is very often about the bereavement before. It's not about this one. You do get the overlapping griefs and bereavements and the contextual and grieving different things. And Robert alluded earlier to sort of like loss of role and loss of financial security, all sorts of bereavements that happen that provide the context for the thing that we actually call the bereavement. Something to think about from a chaplaincy point of view is, who are we helping? Who is it we're there to help? And there are those who are to be or have been bereaved. That's quite obvious, the bereaved. And as many people attending this conference are bereavement counsellors or have done that sort of work, very often it's about the people who are left behind. But as I mentioned earlier, there's also the person who's dying and the grief that they have for themselves and for experiences and things that they were looking forward to that are that they're now going to be deprived of. And there's a grief in themselves for themselves. So those previous bereavements that happen and concurrent bereavements provide the context for the current bereavement. We don't really come to any bereavement absolutely fresh. Once in a while, I have done funerals where people have come to me and they're maybe 50, 60 years old, and they're burying their first parent who's died, and it is the first time they've done it, and they're a bit lost. And to them, that's the first big bereavement of their life. And yet there will be other things that predate that. And so we do have to be conscious of the layers of bereavement, the different and unresolved experiences, family tensions not addressed, unhappiness with how somebody died in hospital, the care they received, all sorts of things. So I do think there's something very important about deferred bereavement, that this bereavement provides the occasion for working through the last bereavement. It's now sufficiently distant in time that we can do the last one, but now we're going to do it. And this one will be, in some sense, be deferred. So my involvement as a chaplain, as a priest, may be episodic, but I'm dealing with more than one bereavement at a time, as they are themselves. In the few visits, or the one immediately after death, or in the hospital funeral. So in a sense, what do we add as chaplains? I don't think we should underestimate what can be done, even in a relatively short period. The funerals that we do, contract funerals, which, as I said, are very often of people who have no one to grieve them, or the people who come to grieve are friends or care home staff or others who aren't the directly related person, or sometimes it's the family and there just wasn't the money to pay for a funeral. The funerals that we do sometimes with no attenders, and especially the paediatric funerals where a family have lost a child and don't feel able to come to the funeral, and those are particularly sad and particularly poignant. And very often you wish there was some way you could reach out to these people and provide them support, but very often the instruction will be on the funeral arrangement form, parents wish no contact. And I always think that's terribly sad. And you worry for those people, and you worry for how they're going to process the loss of a very much wanted child, and yet they don't feel they can be there and do that last thing. So we are there. And once or twice I've had somebody get back in touch with me and say, I didn't come to the funeral, but I wish I had. Can you tell me what happened? Can you tell me what you did? And I'm glad that we did a full funeral, even though there were no mourners present.
Father Giles,
Yeah.
I don't think lots of people here would have had an idea of the range of works that are undertaken by chaplains in hospitals such as yours, and it's been very illuminating. Now, obviously, during COVID, we're very aware that families were unable to come into the hospital setting. Indeed, at our local hospital at Hillingdon, we still can't go in. Was it the case that you were able to go in to be with people as they were dying? And was that something you could reassure families afterwards?
Yeah, I mean, so it varied from hospital to hospital. Within our trust, we were able to go, we were able to visit on the wards. That wasn't a problem. We wore the PPE. I know in some hospital chaplaincies that wasn't the case. Either the hospital told them, no, you can't. And in some chaplaincies, perhaps the chaplains were older, or maybe they had other things going on and didn't feel they could offer that service. But we certainly were on the wards. We were at work every day. Something Robert said earlier about feeling privileged that he carried on going to work. That's very much something that we were able to do. There were things around how do we maintain contact with families, and between us, ward staff, got quite good at using things like iPads, FaceTime, things like that. So, I mean, more than once, I've done the last rites where a nurse stood holding an iPad so that people who would have been there could observe it, but also people who were actually all over the world and would not have been able to observe it normally. So there were things we learned and things that were helpful.
That's good to hear, Father Giles. And one final thing before we move on to Sharon, we're going to have an opportunity for questions and answers. Please do use the Q&A button on the bottom of your screen, delegates, and throw some questions in, not just for Father Giles, but for Sharon when she becomes on the screen. Father Giles, you mentioned that people often don't engage with the chaplaincy services at the time, either because they couldn't or they weren't ready to. Is the chaplaincy service available for people after their loss? Could they come back if they've lost somebody 6 months ago and they weren't able to be present?
Yeah, I mean, we always say, if there's anything we can do in the weeks and months ahead, please feel free to come back to us and talk to us. It's quite unusual that they do. But there are certain people, and there was a slide toward the end of the presentation that I didn't get to, that talks about people who will phone up maybe on the anniversary, or if they're Catholics. There's one person in particular who asks for a requiem mass for his mum on the anniversary of her death each year at Charing Cross, where she died. Okay. I'd say that's unusual. In majority of cases, even sometimes we will try and actively hand people back to their parishes, but in the end, very often it's a fleeting encounter, and people going. It's almost as if once the death has happened in hospital and we've done what we do in an immediate sense, they want to move on. It's part of their grieving, and you don't always. And sometimes the people who do come back to us are actually the people who are stuck and they can't leave the hospital in an emotional sense.
Okay. I think it's been fascinating. Thank you, Father Giles. 2 words that stick with me are momentary and immediacy. And I don't think I thought about hospital chaplaincy in that way before. We will have you back on the screen again before too long. Do send some questions in on the Q&A button if you can. Now, I'm absolutely delighted that we're joined today by Sharon Merchant. Sharon will introduce herself. She's well known to lots of you on here, I'm sure. Sharon, over to you.
Right. Hello, all. I hope you can hear me. I'm very pleased to be here. When I was first asked to attend this conference, I wasn't quite sure where to start. First of all, let me just start by introducing myself. I'm Sharon Merchant. I'm the Bereavement Services Regional Lead for London for the charity Child Bereavement UK. And I've been working with them for a number of years. I've been working with bereavement also ever since training to be a counsellor. So I like to think I've got some experience, but I'm forever learning. The majority of my work is with families, bereaved families. I work with mothers, parents who are bereaved of a child, dealing with stillbirths, miscarriages, children who are bereaved of a loved one. And what is really lovely about my work is that I can work in a holistic way with the whole family. Generally, when I work in a service or other services, it's one or the other. We're allowed to work with everybody. So there is a lot of learning to do. So just wanted to start with, I know we're all here, talking about bereavement, but I just wanted to kind of, more of a definition about what loss is. Loss is a state of, not having something. And as a result of that, the response to that loss is grief. And bereavement is being deprived of something or someone that we had and no longer going to be there. And it's the beginning of a lengthy process of adjustment. And one of the models that we use is Warden's. I don't know if any of you, William Warden, 2009, The Tasks of Mourning. And the reason why it's referred to as a task, because grieving is really, really difficult. It's hard work. And we don't all grieve in the same way. And the tasks that are there is firstly accepting the reality of that loss. And, getting to a funeral, doing a memorial, speaking about the person, there are factors that affect the grief, but at least it's a way of accepting that that person has died. Sometimes it can be quite complex. But I can maybe look into that a little bit later. But you'd often hear people saying things like, I just can't believe that that person has gone and I'll never see them again. And this can be an indicator that they're still learning to accept the reality of that loss. Then there's about processing the pain of that grief. It's just so painful. And I've heard people talk about the physical pain. Many times I ask, where is this pain? Sometimes it's in their throat, which means they can't talk. Sometimes it's in the stomach, they're carrying that pain in their stomach. And so it's always quite useful to note where the pain is. With children, I tend to ask them to draw where it is. And it's quite interesting what children do come up with. The next task is adjusting to the world without the person who died. And it can mean something different to all of us, depending on the relationship to that person. For a child, it's something as simple as who would be driving me to football? But we can't always assume that the person who died, there was a good relationship. And the last of the task is adjusting to that new normal while still trying to feel connected to that person who died. There's an invisible string. Our grief just doesn't disappear. We keep it with us while keeping connected to the person who died, while we grow and change in our lives. There's another model that we use. It's a strobe and shoot model. It's about, on the one hand, how we try and focus on that loss. And on the other hand, we get on with our everyday things to distract us from the grief. One hand, we might have counseling. We might think about how that grief intrudes in our life. There's that denial. And on the other hand, we might, go back to work, do things to try and distract us from the grief. The denial, the avoidance still could be there, but, it's about trying to take on a different role in life. So sometimes we get new roles, we adapt to new identity, have new relationships. So it's about planning for the future. And what you'll find is that with grief, you tend to jump from one to the other. There could be a trigger, and you're going right back to that loss-oriented stage. And then something else happens again, and you feel you're in that restorative mode. And with children, what I've been told by teachers and parents, they get quite confused because one day a child would be, or one moment, should I say, a child would be, happy, playing with their friends, and all of a moment, in a moment they're crying. And I've seen this so much with particularly when doing group work, that a child will be quite happy, laughing. Next minute they're crying because something is just been triggered and they're missing the person who died. So that's one of the models we use. Previously, everybody thought that grief, got smaller. You get smaller and it will, diminish, and, you get on with life, and, everything will change. Then it was found that no, that's not true. So the Tompkins model is about finding an enduring connection. The grief doesn't get smaller. It can be all consuming at first, but as we accept the reality of the loss, process the pain, adjust to the world without the person who died in it, and find that enduring connection, we're able to carry our grief with us, but able to continue with life and to continue to grow and change as people. And I think sometimes, I try to explain this to people, and with young people, with children, I say, you'll go on, you'll do, other things, you'll have friends, you'll go on to, secondary school. From secondary school, you'll be thinking about your GCSEs. And so the world around them is growing, but it doesn't mean that they forget about that person. And sometimes people find that quite comforting, because one of the things that people are sometimes worried about, particularly young people, is forgetting that person who died. They're so scared of forgetting them. And so we try to do things. I try to do things to keep that connection going, find something that connects them to that person. And with parents as well, sometimes it's having a little, I'd say an altar, but something that, a place where they can go, or sometimes within the home. Now we talk about COVID, and COVID was a particularly difficult time, not only for the families, but for also us as practitioners, because our norm was meeting people face to face. And we had to adapt, So it was like the loss for us of not being able to meet with people, not being able to connect with them, physically. And this whole world, like what we're doing now, Zoom, and trying to adjust to Teams and all this, this, and being creative also using this medium. So that was quite difficult, because during the pandemic, there were those who had families who died from COVID. But, I know everyone focused on COVID, but there were other deaths as well. There were suicides. There's the tragedies of tragic deaths like murder. They still took place. And so it was difficult for families not to be able to either go to hospital or to meet with family members, to even attend funerals. So it was a very, very difficult time. And, it's now changing, thank goodness, but it was trying to adapt to that world without doing the normal rituals that we were once able to do. The other thing, there's factors that, affect the grieving process. And as I said, COVID was one factor that did affect it because of things that they were able to do. But also relationships with the person who died. People often think that the relationship was a good one, but the parent who died, was that a good parent? Was that bad parent? We often get families who were in domestic violence situations where a person died, and sometimes there was some relief, and there's guilt about feeling, a relief. But most often it was a good relationship, and that's what makes that death so difficult as well. We also have to think about the individual who's in front of us. What is their culture, their previous experience of death? And I think that was touched upon today. What was the personality of that person? It's also about thinking about the environment that one lives in. Is it a supportive environment? Is it a chaotic environment? Were they able to ask questions? Are they able to ask questions and get an honest answer? And one of the things we often encourage is just to be open and honest with young people. So no two circumstances are the same in the family. None is worse than other. There's no hierarchy with death. And we also have to think about the type of death. Was it sudden? Was it terminal? Was it suicide? Was it an accident? And, you know, as I said, about the link of the relationship to the person who died. So there's quite a few factors to consider. And going back to COVID, it created a lot of fear. Not, you know, in all of us, there was a climate of fear. And with young people in particular, there was the fear of this thing that was out there. They weren't able to go to school, meet with their school friends. They weren't able to see their teachers. Sometimes that was a place of safety for them. So not being able to connect and yet having a death as well, there was a lot of fear. Would it come to them? And I had young people who were actually scared to go out of their home. There was those whose parents were, or family members were caregivers, nurses. There was a lot of worry about whether they would come home safe. And sometimes, you know, there was a lot of anger. And there is anger when death occurs anyway, because there's a lack of understanding and why me? And it also happens with the parents who are bereaved of a child. With children, it depends, they make sense of death depending on their ages and their development. So up until 6 months, they're aware that somebody is not there. There's the withdrawal of that familiar person. And they might show it by being insecure, crying, disrupted sleep and feeding. Between 6 months to 2 years old, they can miss someone. And there is separation anxiety, and there's a searching behavior. You might see that that child is searching. And between 5 to 8, 2 to 5, they're interested in death, but they don't have that sense. They know someone's died, but they're expecting them to return. And that's why we're kind of mindful of the language that parents or, you know, people use, that they've gone away or they're asleep, because then the child is expecting that person to return or wake up. 5 to 8, there's a fuller understanding of death. And, you know, there's that age of magical thinking, the fear of death. 8 to 12, and as they get older, they understand and they start to worry about their own health and death. So if we're looking at those ages, and particularly 8 to 12-year-olds, with COVID having been in the background, there was, and still exists, this anxiety about what could happen to them. What I thought was would be quite useful is just for those who work with young people, is just to look at ways that they could be creative. First of all, it's about thinking about what young people need from us, because often people are not quite sure. They just want to know what's happened. They want comfort and reassurance, space, time to grieve, someone to share their journey, ways to express their grief, and they need help to build resilience, and above all, be allowed to have fun. And I think we say it about children, but I think that that's for all of us. You know, we all need time to grieve and to express ourselves, etc. So I know that, you know, most of this is about adults, but I thought that it'd be good to just give some creative tips about what one can do with a child. And some of you might be counselors, and you might do, you know, think of do some memory work about the person who died. And one of the things that we do is a salt jar. And we get the child to think about different colors that remind them of the person who died, and to, you know, create different colors using pastels and salt, and giving them something to kind of remind them. And they quite like that. Another thing that we do is who's there for you. And on the tree, or using, you know, hand cutout, thinking of the people who are there for them, because it can be quite an isolating time. But just looking, you know, and thinking about, actually, I've got this person, I've got that person, makes them feel a lot better. I think I've spoken about body mapping, you know, the feelings in the body. And then there's a first aid kit, which is about resilience, things that you can put in a kit to make you stronger. With the young people, what we found is there has been a demand for group work. And it was touched on earlier that the importance of group work. Young people have felt very isolated, especially during COVID. And some of those kind of broke the rules, and you know, some of them broke the rules and were out and about because they needed to connect with others. They needed to have some reassurance that everything was okay. And within the service, we try to keep the group work going, and it's been something that's been invaluable. We haven't been doing it in London due to staff shortages, but throughout the rest of the services, it's been going, and it's a place where they've been able to connect via Zoom with other young people and to explore what being in a lockdown has meant to them, being away from, you know, friends and family, not family so much, but yes, and even family, and not being able to connect and not being able to be part of a ritual, you know, to remember that person who died, what that has meant for them. So those things have been invaluable. I just wanted to read before a quote from Silverman, 2012. It says, "We learn to live in the world differently. We do not put the past behind us. Instead, we find ways of carrying it into the future, recognizing how these deeply felt emotions and experiences make us who we are today and who we will become." And I think it's really important to start with young people. There are a lot of services that don't cater for young people, because it's been shown that young people who don't deal with bereavement, who don't get the opportunity to deal with bereavement, later go on to offend or have mental health issues. So it's really important that we're able to give them the opportunity to discuss. Sometimes people find it difficult to talk to young people, don't know what to say, don't know the right questions to ask, and you don't have to be an expert. It's just about listening and giving empathy. And if you don't know something, ask. If you know, a child would much rather that you ask the questions because it shows that you care. I don't think any answer, you know, or any question could be wrong. Maybe it's just about saying, "I don't understand. Could you, you know, tell me how you feel?" And listening goes a very, very long way. And it's about active listening, showing that you're nodding your head, you're understanding. If you don't understand, I did you ask? And that would mean so much to a child. It means so much to anybody who's been bereaved, never mind a young child. So I hope that you will put some stuff in the question and answers. Happy to answer anything.
Actually, we've got lots of questions coming through, Sharon. Oh. You've been an absolute a lovely contrast to Father Giles, who was very much into the momentary and the immediacy because he's there at that moment of passing. Yours is a much more holistic, seeing the person, the deceased person, and also their immediate family and friends as a personality, and you're building up a story around them, and how their relationships will play out and their previous experiences of death. So you've come from a very different school of thought. You're working in a very different setting. So and I think the questions that are starting to come through are reflecting that for both of you, which is wonderful. Is it a good moment to bring Father Giles back in? Shall we start some questions? Sharon, is there anything else you'd like to add onto the floor to the delegates without the questions first?
No, maybe some of the questions will bring up some
yeah, I think there's some really good questions actually, so it'd be good to give them some time. Do forgive me, everybody, for looking at my mobile phone. I'm not being rude. The questions are on my phone, so I'm gonna start with Father Giles. And then there's a couple of joint questions that I'm going to throw in as well that were a legacy from the last meeting. We haven't forgotten any of your questions. Father Giles, this is from John from Hayes. How could you help someone who has lost their faith due to illness and death?
That's a very good question. And it depends what you mean by help. I think if you mean how do you help them recover their faith, I'm not sure you can do anything in a prescriptive sense to do that. But certainly, if they have lost something that's presumably as precious to them as their faith because of a bereavement, then that particular loss within that bereavement isn't something you can just see by itself. It's not just the loss of faith that we're dealing with. They probably suffered a great quite a trauma to their sense of self, and they may well have lost. Their loss of faith may be symptomatic of a loss of sense of the other things that made them up. So I guess that if I were a parish priest and I had somebody come to me and say, Father, after Mum died, I lost my faith. The first thing I'd take from that is the fact that they actually had come to me. They've lost their faith, but they've come to me. So it's something they want back. And how I would then take it on from there would be very much about why they felt, what were the particular shocks to their system, their shocks to their sense of belief. What was it about their faith that was so rocked by this loss? Because I suppose, to take the opposite situation, you get people who, they suffer a bereavement and they have a tremendous coping mechanism in their faith, in the sense that the person who has died has not ceased to be, but has gone on to something better. And so I guess it would be very much a case of me asking them, well, okay, I understand that you feel you've lost your faith because of this particular bereavement, and trying to find out what parts of the faith were actually challenged by it or unequal to the task of what they felt they were suffering in their bereavement. But I don't think there's any one way of dealing with that. I mean, people certainly will say that they've lost their faith because of some shock to them, and it might be a bereavement, it might be something else, but certainly the fact that they came to me to say that suggests that they think they've lost their faith, but then if they've lost it, why have they come to me? There's something still in there.
Yeah, I think that's a very valid point.
Angela, sorry, I was just going to say, it's something that, people bring to session quite a bit. We have people of all different faiths come to us, and it's something strong believers come, there's quite a few of them. Some of them, their faith is strengthened, and others, why would God do this to them? And what I always say to them is, you can have a conversation with him. Yeah. If you're angry, you can tell him, he will listen. And, I said, death comes to us all. It comes at different stages. We assume that it's going to be 70, but, people die at all different ages, and, it's a loss that we feel. However, by reconnecting and speaking, there can be peace found, and people have come back to me and said, because I kind of said, okay, what does it feel like now? There's a vacuum, there's something missing. But you can fill it with, I'm not there as a priest or anything, but just, when people bring that as a person-centered person, counselor, when people bring that, what do you want to fill it with? And invariably they do want to go back to their faith, but they're angry. And I say, have that conversation with God. Yeah. And then they come back and a bit later and they say, actually, Sharon, you're right. And they feel a sense of peace.
Yeah. They don't want to be initially angry with God, do they?
No, but I say it's okay. Have that conversation.
But, yeah, absolutely. Yeah. That's the whole point of prayer, isn't it? It's a conversation with God. So let's have that conversation. God knows what you're going to say.
Yes. Yeah.
Right. This is to both of you, and it's similar but slightly different. We've got Mary Ellen Barker has said, how do we deal with somebody who has continuous mourning and grieving? So it's almost that they haven't got the strobe and shoot model they're working to. And following on from that, Josie Brown wanted to know, how can we help someone who's stuck in their bereavement journey? So we've got somebody who's stuck continuously mourning and somebody who's stuck in their bereavement journey, presumably at one stage. Slightly different, but relevant to each other. That's why I've linked them together.
Right. I mean, I always find that, I must admit, it's very difficult, because I do have families, and I've had clients who, you know, it's complicated grief when they're not moving on, and others who are just stuck. And what I have found, particularly with parents who are stuck there, it's almost like there's a sense of comfort. And you know, when I ask them, what does it feel like? And it does sometimes feel like there's a sense of comfort staying there with that grief. It's something for them to hold on to. And there's almost like there's a sense of guilt if they stop feeling this. So it's just trying to work with, what does it feel like to take one foot out of that grief? You know, you don't have to take both at a time, but gently just take a foot out and see what that feels like. You know, you're never going to forget, you're never going to stop feeling, but it's okay to try and to move out of that. So I try to encourage people to move out of that. And if something if someone is really, really stuck, is there something more? Is there something added to this? Is there something more than just the grief? Is there something around that's kind of holding them there? It's actually
Father Giles speaks as well, Sharon. Yeah. This might tie in with this. What would you particularly put in this first aid kit? This is the time at which someone might need a first aid kit, a resilience kit. What would you suggest putting in it? What could we give to people that might help?
So is that question to me?
Yeah, it is. And then both back to Father Giles, really, as well.
Okay, so it's things that you know, if I was talking to an adult, what do you enjoy doing? You know, so if the first aid kit, it would be, you know, maybe a diary, maybe something to write my feelings, listening to music, you know, music that calms you, you know, it could even be going for walks and doing things like that. It's something in there that gives you that resilience and that strength. It could be prayer, you know, rituals, anything that brings some sense of comfort. That's what I would, you know, but I would work with them to find out what works for them, because what might be in a resilient kit for one person might not be in for the other person. But writing feelings down, you know, thoughts and feelings down, having, you know, as I say, maybe for somebody, it might be prayer, it might be affirmations, listening to music, those kind of things.
No, that's brilliant. Thank you. That's really addressed that nicely. I know that's come through from a couple of people. Father Giles, what about yourself? You know, we've got this people who may be stuck, people who are unable to do anything but grieving at this point. And then obviously, what would you throw into a first aid kit?
I mean, it's interesting because obviously people going to see Sharon would be going on a slightly different basis than someone coming to see me. And again, almost because they come to see me, that kind of starts suggesting what they're looking for to some extent. Not always. I mean, sometimes people will come to priest, to clergy, simply because they think we'll listen. But on the other hand, bearing in mind what I am when they come to me, so my thoughts would be more towards, you know, trying to reestablish the prayer life, the dialogue of prayer with God. And maybe in the course of I'm thinking about one person in particular, that one of the things that had happened during the course of their parents' long decline and then death was that in the end they hadn't been able to get to church at all, and it had just fallen out of their habits. And then when their parent died, they then found themselves, you know, adrift, because they didn't have the habits of normal life, because so much had happened around the care they'd been giving to their parent. And so saying, well, you know, how about, you know, going back to mass, because that's something that you valued before and could value again. And certainly, that going back to sorry, I've just got something banging on my door. Sorry. What I was saying, so going back to refinding habits that they'd found helpful and which had been disrupted by the process of the dying. So a sort of, refinding a normality that had preceded the loss. And that might be in prayer, that might be in going to Mass, it might be other things to do with the community around the church, and re-establishing themselves as part of that community, having been alienated from it because they've been a carer.
Absolutely. No, that's a great thing to throw into the toolbox, that readjusting back to different weekly or daily habits. That's a wonderful thing. Sharon, anything else you'd like to add on that point about the idea of a resistant grief that is stuck, or a continuous grief, before we move on to any other questions?
No.
No, brilliant. Okay, that's wonderful. We're going to move on now to Sharon. I'm throwing one at you again. This is from Carol Binish. Have you got some thoughts on how we can work with families of someone terminally ill, especially children? Now, I'm guessing it's the child that you're working with, that it's not the child who's terminally ill, I think. But Carol, do correct me if I haven't interpreted that right.
Yeah, I mean, I think it's really important to spend as much time with the person who, the family together, doing things together and creating memories. It's really important. And that's one of the things during the lockdown that has been difficult, because children have not been able to do that, and it kind of heightens their sense of loss. So I was encouraged to start doing, like a memory book, all those things that they, and trying to record. Sometimes it could be like a video, it could be dad speaking or mum speaking, whoever the person who's died, could be nan speaking, they could be leaving a little message. Just doing creative things together. But it's about trying to do something to remember that person when that person has died.
Yeah, absolutely. Great idea there. Thank you. Back to Father Giles. This is from Anne-Marie. Father Giles, is there a way, well, actually, it could be to Sharon too, to be fair, but I'm going to go Father Giles to start with. How could hospitals or hospices make better use of the post-pandemic period to change services that they might offer for people dying at home? So there's no limit to visitors, that kind of thing. Is that something that's being considered at all?
Well, if you're talking particularly about hospices and about, say, palliative care situations, when someone's discharged from hospital, to a hospice or from the hospice, they will very often be handed over to a community palliative care team. So there's a sort of a handover, and there is a kind of quite boundary, health care provision works in a quite boundaried way. So once someone has left your care, you hand them on to the next stage. So people are not left bereft simply because they've been discharged from hospital or they've been discharged from hospice. There are community palliative care teams. There are community services, and there are, obviously, in the case of somebody who's a person of faith, then there is a parish or a synagogue or a mosque or whatever that perhaps we can hand them back to. In terms of how can things be done differently, I think maybe developing the community model, the community team model a bit more, so that people who want to die at home can. But there is hospice at home. There is community palliative care. So actually, I think there's quite a lot already in place that does provide for people outside of primary and secondary healthcare context, people at home, and
that's good to know.
District nurses, carers, community palliative care, all of those things I think do exist. They could probably be developed, and everything in the health service could be better funded. But it's not like people who are currently bereft. I mean, clearly in COVID, a lot of things fell over because people were so scared of death and that risk, and we need to put them back where they've fallen over. But conceptually, they are there and they do exist.
Absolutely, thank you. What about you, Sharon? Is that something you pick up then when people from hospital chaplaincies pass to you? Is that quite slick at the moment, or as Father Giles says, is it still quite?
I think it's still, kind of, it's not something that, families will come and tell us, I don't do that much pre-bereavement work. You know, we're getting some of it, but what I do find that is if someone can be at home amongst their loved ones, it makes that transition so much easier for the family. And just touching a little bit about the question that Carol asked previously, communication with the children is key. No matter where the loved one is, it's about communicating them what is happening and what is likely to happen. And if they're at home, yes, it makes it easier because they're there. So long as they're not shut out, it's about them being involved, you know, in a way that's safe for them, but, you know, being open and honest.
I think that's a very, very, very fair point. Coming back to that kind of transition between hospital or hospice and home, if people are choosing to die at home, and the support for their family and themselves there, does that then fall straight under the palliative care team on discharge from hospital? How, if you're not part of a faith community, like Father Giles was saying, well, we'll transfer them to the parish priest. I guess the same is the same in all the faiths. Do you know how that join up happens, or is that something families should try to ensure and bereavement visitors should check are happening?
So you want to answer, Father?
Well, I was going to say, I mean, certainly, I attend multidisciplinary team meetings where we're talking about discharge, and one of the things that has to be done by a palliative care team in hospital when someone is discharged is a formal handover has to be made to the community palliative care team or to the hospice to which they are going. And one of the options for our ongoing thing is hospice at home, and again, that would be a formal handover. So in those, and certainly one of the things that happens around that is that if we feel that the family presents a particular bereavement risk, so by which I mean you have, say, somebody in a very close relationship with the person who's dying, who is going to suffer potentially quite, you know, profound psychological distress, and even to the point of being at risk of harming themselves, then there are formal referral mechanisms that make sure that people like that shouldn't be dropped.
That's good to know. And that's still happening now. It's back up and running after the COVID 18 months. That's back. Okay.
Yeah, I mean, bereavement risk is not something that ever went away as a concept. It's just how was it delivered, and that has been more difficult.
Perfect. Thank you, Father Giles. And Sharon, would that be your experience too? That's how the system kicks in.
Yeah, but I think we tend to deal more with, you know, particularly if a child is dying, that the parent can go to the hospice and spend time. I think they're still able to do that, or it's definitely kicking back in now. Spend time with the child, the family be able to do that, which really helps.
Okay. Yeah, and that being, and also in hospital and hospice, although we aren't having very much by way of active visiting, certainly not full-blown visiting, when someone is at the end of life, their families are definitely allowed to visit, so they'll be transferred to a side room. Mm-hmm. You know, and it was realised that one of the things that went very badly wrong early on in COVID was, you know, people being put in the back of an ambulance and taken away and never seen again, and that was a horrendous injustice, and we aren't doing that anymore.
Okay, that's also good to know, because we are working with the bereaved, and so it's good to know what their experience pre-bereavement was. Right, another one for you, Sharon, here. This is from Joan Arnold. How do you deal with a child faced with a step parent having lost their mother or father, and they feel guilty about transferring their love?
I laugh because that is quite a common one. Yeah. And I think it's once that's that step parent and assuring the child that the step parent is not there to take the place of the person who died. They're just there to, you know, they're filling a space, but they're not taking that place. And they're there to give love and carry on the family cycle. But, and it's very important for the family to make sure that that child knows that mum or dad or whoever died, well, mum or dad, is not going to be forgotten. And that's the step parent, you know, ensures that that child is allowed to talk about mummy or daddy and can have their little rituals and all the things that make them happy, honor the birthdays and, you know, all the things that they want to. I think that's really important, and that helps to overcome that.
Okay, brilliant. Thank you. Kay Sadler asked a question I'm sure lots of us are wondering. Could you explain body mapping to us, please?
Oh God, it's when I get started. It's just, I think I talked a little bit. It's about looking the parts of the body where things are. Like you say, my heart hurts, and so they might do to the heart. Tummy hurts, might point to the tummy. It's all the places in the body where they feel things.
Okay.
And so kind of pinpointing those parts of the body where they're feeling something.
And presumably that can change from one session to the next with them. So it's a good thing to do lots of times.
Yes,
times.
Yeah.
And are you hoping as a therapist that body map, that pain will lessen or change?
Well, it could be that their heart feels healed and so it doesn't have to be always something painful. It can start to be something quite joyous.
Okay, so the body mapping can be positive as well.
Yeah.
Okay, that's a good point. I hope, Joan, that answers your question. Father Giles, okay. How do you cope after dealing with a bereavement in hospital when you go home?
That's interesting. I think, okay, if I sort of wind back about sort of 2 hours from that point, which is, my phone goes at, say, 2 o'clock in the morning or whatever. And we're all human. So there's a sense at which at that moment when your phone goes, and you've got to get up at 2 o'clock in the morning, your heart sinks, but then you very quickly have to remind yourself that actually the reason you're being called is because somebody is having a considerably worse night than you are. And by the time you arrive at the bedside, I think the way I describe it is it's a grace of God that actually your mind has been kind of reset, so that by the time you arrive at the bedside, you are aware very much of the privilege of being with somebody in their dying moments. And it is a tremendous privilege, because in the moments of somebody's dying is a very, in the most general sense, a very intimate moment. Birth, death. It's and so to be allowed in, perhaps not knowing them at all or not knowing them very much, and being welcomed in by the family is a tremendous privilege, and that's very important. So then we do what we do, and we might do some ritual, the last rites, which would be normal, and we might speak with the family for a while, although actually typically at that point people don't necessarily want to talk very much about what's happened. They want to know that the right things have been done, and they want to know what happens next in a practical sense. So, by the time you leave the room, I very often feel, I feel a sense of, for want of a better word, a satisfaction that we have supported somebody who is dying and their family in the way that they want to be supported and need to be supported. And so there's a satisfaction to that, and a sense of privilege. So it's not all about burden. Sometimes there'll be a particular death which for some reason maybe reminds you of your own parents' death or something, and it gets to you. Or I remember one occasion when there was a child who died in the paediatric intensive care unit, and after that particular situation, I just went and sat in the chapel for half an hour, and I couldn't, and I actually did feel quite kind of disabled. I just had to go and sit there, and basically say to God, I can't quite deal with this. Here you are, you deal with it. But as a rule, I think, without wishing to sound callous, I think you develop a certain kind of, not thick skin, but you develop, you have kind of you become used to that situation. But the positive side of it, as I say, is that is the sense that you've done what needed to be done, and that's a satisfaction, and the privilege of being involved in a very intimate moment in someone's dying, I think, is, again, for want of a better word, there's a positive side to that experience. It's not all negative and not all about burden.
Okay, thank you, Father Giles. That was a question from Ruth Taylor, and I think it's such a valid one for all of us as bereavement visitors. I'm going to put it to Sharon as well, because self-care is, we would say in the church, an empty jug cannot pour. And so Sharon, any tips you've got as well for how you deal when you go home?
I mean, during the pandemic, it was extremely difficult because normally in the office setting, you can talk to your colleagues. They would sense when you've had a difficult session. Being at home, there was no one to take it. So what I've done when I'm at home, I've gone out for a walk.
Okay.
You know, I've taken myself, and what I've tried to do is separate my, my workspace from my living space so that I have somewhere else to go. And I would just switch the TV on, look at something that just takes my mind off of it. But sometimes I do reflect on what has happened. Why has it impacted me so greatly? And process it, and maybe share it with a colleague whilst I've been at home. Going back to face, it is easier now. But I try to, something that I can unwind. Usually a walk helps.
Okay. Yeah, that's good. Thank you. They're really handy hints from both of you. Couple of probably a bit quicker ones, really, because there's a yes or a no answer to this. At what age can you see a child alone? And that's from John Spencer.
I've started seeing children from the age of 4 alone. Once we have parental consent, and the parent is always, or carer is nearby outside the door, but I have started from 4. It's not usual because they're understanding of what's going on, but from 4.
Okay, brilliant. What about you, Father Giles? Is that something that even occurs for you, or?
Well, yes, in the sense that we will go to the bedside of anybody of any age. Typically, if it's a very small child, there will be in PICU, paediatric intensive care, or paediatric ward, and very often being nursed 1-to-1. So there very often be a nurse in the room or at the bedside or very close by. So in a sense, we're not seeing them alone. That said, as I'm sure with Sharon's case, we are DBS enhanced checked. So in that sense, we are allowed to be alone with anybody, adult or child, who is vulnerable, and we obey all the rules and whatever. So, but I would say for us, it's unusual to be completely alone with a child, because that's just not the situation.
Yeah, it's a different setting, isn't it, for you completely? This is from Geraldine Fay, and it's for Sharon. What techniques have you used when dealing with older teenagers, say 16 plus, to help them work with their grief? And maybe as importantly, what doesn't work?
I'm just trying to think. I think with older teenagers, because they're kind of, the creative stuff that you would do before, but some of the creative things I still allow them to do. Like sometimes I'd have a mask. I have a mask, and what are your feelings? And this works with adults as well. Show me your feelings, because sometimes the outside of the mask might, what they show the world. The inside might be what they're really feeling. So that quite works. But I think it's just giving them that chance to talk, to name the feelings. Just a safe space where they know that they're not going to be judged. Nothing's silly or shouldn't be said. Just that space to be able to talk. And it's a safe, confidential space. I think they value that more than anything else. So in terms of techniques, it depends on each individual. Sometimes I go in with, I'm going to do this, and something else comes. So it really does depend. What I pull out the toolbox depends on who's in front of me.
Yeah, no, safe and confidential feels just what a 16-year-old kind of wants to know, isn't it, really?
Yeah.
So that's wonderful. Father Giles, this is from Jane Harrison. Are you aware if the hospitals that you cover and are involved in have backup, e.g. people like SANS, for patients who've lost a child in hospital?
Okay, so we have. Okay, so if you talk about very small children, so neonates and stillbirths, we have bereavement midwife service. So we've had one of these very recently, where a mother has been told that a child will not survive birth. So they are immediately put into the hands of the bereavement midwife team. And they usually contact us if there's any kind of faith involvement. Sometimes if there's not, they just feel that it would be helpful to have somebody non-clinical to talk to, and that can be helpful. If you talk about older children, so not neonates, not very small children, then we have a family liaison service, and there are two nurses who are specialist nurses for family support. And again, if a child is in one of our paediatric wards, all of which are at St Mary's, and is approaching the end of their life, they will be referred into the hands of the family liaison service, and again passed to us, and then family liaison will put them in touch, I think, with people in the community who can provide longer term bereavement support and care.
Okay, thank you. That's really informative. And actually, this might lead into a question that's come through just now to both of you, really. But what access do both of you have to referrals to other faith groups? Are you able to refer? I mean, obviously, we Catholics can refer to Catholics, but how are you able to do that in your settings?
Well, I'll answer. It would depend why we would need to refer them on.
Okay.
If we're dealing with grief, grief is universal. It's not about a faith or a religion or anything like that. It's about feelings, and those feelings are all universal. However, if there's something else that is more pressing that they, that their community group can deal with, then I would find out who to refer them on to.
Okay, brilliant. Thank you. And what about yourself, Father Giles? In a hospital chaplaincy, can you access all the other chaplains?
Oh yeah, I mean, A is the lead chaplain. I mean, my position is non-denominational. It could be held by a Muslim. It could be held by anybody. It's certainly not a Catholic position, but certainly when you go and see somebody in the context of a bereavement, then very often there will be a faith component. That's why we were asked in, but not always. Sometimes it would have been misunderstood what they were. So sometimes, an Orthodox Christian would have asked to see someone, the rabbi gets sent because because the nurse thought they said Orthodox Jew, and so you get a little bit confusion there.
Yeah.
But certainly in our team we have Catholics, Anglicans, Muslims, and Jewish chaplains, and we have contacts in the community with Sikhs, Hindus, all sorts of things that we may need to refer to. So if somebody says, I would like to see a chaplain, well, we offer our services, and if they want somebody who is not part of the team, we will then find somebody and bring them in.
Okay, that's good to know that support's out there for people to make sure we request that for people. I've just got two more questions for you because we are coming to the end. Firstly, this is from Carol Scarlett. How can we support a child online creatively? Online. Might be better suited for Sharon than Giles, but we've got the idea. Giles, throw them in.
Okay, so firstly, online with Zoom, there's the whiteboard. So you can enable the child to draw things, write things on the whiteboard. I'm not the greatest, to be quite honest, when it comes to that. But what I have done is allow the child to maybe draw things. We can talk about things, and they draw them, and they share them with me. So it's just allowing them to do what they can do from their end. Just trying to think what else I do. I think it's mainly using the whiteboard.
Okay.
Mainly using the whiteboard. But as I said, also allowing them to do things from their end and sharing that with me.
Lovely, thank you. I'm guessing, Father Giles, you don't have that's not your, no.
I think the only thing I'd add to that is, as I said earlier, about using iPads and things like that. If you can't see somebody, you do have, and we are now, because of the COVID experience, we are now all a bit more literate with using other means of communication, just face-to-face.
Yeah, perfect, thank you. And one final question, I'm going to fling it to both of you. This is from Emmy McGregor, but possibly more to Sharon. How can she help a parent who cannot accept the death of a child?
Oh, that's so common. It takes time. It takes time. It's about being patient and listening. Eventually, I've had so many parents where that is the case. I don't know how recent the death would be, and even if I've got one. In fact, I saw someone yesterday whose baby died 10 years ago. She still can't accept the death because the circumstances around the death and what that child meant to her, just having a child. So what I do is I try to give her just time and space, because, you know, everyone's different and it takes time. And I think particularly with bereaved parents, it can be a very long process. Yeah. So just do what you do: empathy, time, space. Okay, listen.
Perfect. Beautifully summed up. Thank you, Sharon. I hope that helps, Emmy. Father Giles, would you add anything to that?
Well, I mean, just going back to a little bit about our involvement is very, very kind of episodic and very short term sometimes. And, you know, and the saddest thing is when we're doing the funeral for a child and the parents don't come. That really is, and you do feel that, you know, that's, you know, an opportunity missed. And certainly just once in a while when somebody will get in touch and say, I didn't come and I wish I had. And then you talk through what you did. And then we might signpost people to other sources of help and, you know, bereavement services and things, and maybe talk to the bereavement midwives and say, have they been back in touch with you too? To find out whether they've just reached out to us or whatever. But it, as you know, as Sharon said, it can go on and on, you know, on for years. You know, the non-acceptance of the death of a child is a very common thing, because you don't expect to bury your children, and people find it very difficult to make sense of that.
Okay, thank you, Father Giles, and thank you, Sharon, for answering all our questions so well. On behalf of all the delegates, I say thank you. Questions that you never know what's going to come next, but you did magnificently well, so thank you very much. I pass back to Judy.
Thank you.
Judy, you're muted.
You'd think I would have learnt by now, wouldn't you, at the end of 18, 19 months of this? Apologies. Angela, thank you. Thank you very much. As always, at the end of a conference, there's just so many people to thank, but I really want to thank our presenters, our panellists. I feel that they really have come up with practical solutions that will be able to help our visitors. Certainly, things I'm going to take away, certainly from Robert, I thought, although this was kind of funny but not funny, was the blob bridge. I thought was really interesting in the way he explained it. Also, how to use anger as a positive thing, which I basically have thought of as a negative thing. Again, long silences, possibly repeating what the client had said previously, could be very helpful to us. Very different perspectives from Father Giles and Sharon. Very interesting. Father Giles, I think, emphatically saying that no one's grief is the same as somebody else's, and I think it's something we all know, but it's nice to have reinforced. And I think that nobody's bereavement is the same as somebody else's, especially when there are multiple bereavements. And Sharon, I think, talking about the physical symptoms, very interesting. When you have a pain in your heart, it literally feels it's in the middle of your body, where somebody's stuck a dagger in. And I think you emphasised to me how much that meant. And the continuous grief and creating memories. So I feel I've a lot to take away from today. I hope you delegates do as well. As usual, planning a conference is very much a team effort. And I'd like to thank my colleagues on the committee. That's Angela Atkins, Sharon Goldsmith, Jack Lyons, Bridget Murray, Jenny Reed, Bobby Riesel, and Jem, who is our volunteer minute taker. And he also produced the interval film, which I hope you enjoyed, with our variety of 40-year anniversary titles. David Griffiths, our extremely efficient coordinator, and Zana Sheikh, who has been helping us, helping David in the office. Also, thanks go to Aaron Lyons, who's been helping with the IT. However, my special thanks, as always, goes to John Fiber of Shock Audio Visual. His professional expertise has ensured that the non-techies amongst us have overcome any Zoom issues. He has a wonderful knack of making me feel, after I've spoken to him, that everything is going to be just fine. And it was. Thank you, Internet. And thanks to Martin as well, Martin Lever, for his help with the bookshop. I'm confident, I think, although that doesn't make sense. But I'm confident, I think, that we'll be meeting face to face next year for our 41st conference. Yes, what more can I say? Hopeful. Finally, a reminder, you will get an evaluation sent to you online. Please let us have your feedback. I'm not going to say any more. I'm just going to pass over very briefly to Bobby Riesel, who is Vice Chair of Bereavement Care. Bobby, over to you just to say a few words. You're on mute, Bobby.
Can you hear me now? Yes?
Yes.
So, thank you. Judy has introduced me. I'm Vice Chair of Bereavement Care, and I do hope that you were able to take something good away from today's conference, because I think it was excellent. And a special thank you to all our speakers. But I'm asking you for a few minutes just to put aside the long journey through grief and to think of another long journey. And this time, it's a journey to Mauritius for a week. It's a week's stay with half board, flights included, in a luxury hotel. Now, if that's a journey that appeals to you, we at Bereavement Care may just say we may be able to satisfy those desires. For that week in Mauritius is first prize in our most ambitious raffle ever. The second prize is a John Lewis voucher, and the third prize is a red letter day. You'll want to know where to go and buy the tickets. Well, that means a short journey to our website, which is www.bereavementcareandsupport.co.uk. I think it's on all our note paper, where you'll find full details. If you're invited to give extra for commission, please don't. So do please consider buying and having a chance to win one of these great prizes and help Bereavement Care raise much needed funds. So thank you all very much. And I believe I'm going to hand over to Jack. Okay.
Hello, can you hear me?
Yes.
And can you see me?
Yes.
In that case, I will start. My name is Jack Lyons. I'm very privileged to have the last word today. I was actually, at one time, some while ago, Chair of Bereavement Care. Let me start by saying, even the longest journeys must have an end, and a beginning too. Our conference this year has looked at the long journey, the journey through times of grief. Taking grief away from somebody who is suffering a loss is not the responsibility of the listening visitor, who is privileged to share a small part of their journey. Important as may be the visitor's time with one who mourns, equally important must be the time taken, often from a busy schedule, to reflect and to share. Notwithstanding that visitors may play an important role in giving when they visit, I dare to suggest that on that journey, their lives too will have been enhanced. May we leave this conference not simply better to help our fellow men and women on their long journey, but also thankful for the opportunities afforded to those of us as we accompany them. Thank you very much. Good afternoon.